for the CME RegCon 2020, a tribute to Professor Dr. Shankar Narayanan. If you want to live a happy life, tie it to a goal and not to people or things. This was a quote by scientist Albert Einstein. And this was followed by my father, and it was his life and goal which was tied to regenerative medicine. And this whole conference was a tribute to Professor Dr. S. Shankar Narayanan. His vision was marching ahead from era of resection to regeneration. And I wish all of us students, the future scientists, also march toward the future of medicine, which is regenerative medicine and dentistry.
यो देवश्रुतिशेखरेषु विदितः यं भासकं जानते येन भ्राम्यति लोकजालमखिलं यस्मै नमस्कुर्वते यस्मान्न परमस्ति किञ्चिदपि वै यस्याङ्गभूतं जगत् यस्मिन् तिष्ठति सर्वमेव भुवनं कुर्यात् स नो मङ्गलम्.
நீராறும் கடலுடுத்த நிலமடந்தை கெழிலொழுகும் சீராறும் வதனமென திகழ்பரத கண்டமிதில் வெக்கணமும் அதிச்சிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம் வியந்து செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
The presence of light or fire will ensure success. Light is a symbol of brightness and prosperity, as sunlight expels the darkness. On this note, I request the dignitaries to light the Kuttuvelagam. Chief guest Dr. Manish Khanna, President of Indian Stem Cell Study Group. Chief guest of honor Dr. Ganapati Sundar, Dr. Sendilvel Kumar, National College Principal Professor Sundar Raman, Dr. Nayana Patel, Infertility Specialist from Akansha Hospital, Gujarat, and Dr. Anil Bansali, Professor of Endocrinology from PG, Chandigarh. I request Dr. Ravi, Director of Mother Cell Regenerative Center and Director of Department of Regenerative Medicine, Maruti Hospital, and the Organizing Secretary of this conference to give away the welcome address.
Good morning and warm welcome to all of us from the organizing team to the eminent speakers and dignitaries and the delegates. Today it is an important day for all of us. It's a day of learning. Eminent professors, clinicians and scientists are going to impart us with knowledge. My great friend Dr. Professor Shankar Narayanan introduced me to this field of regenerative medicine. Today it is a tribute to his legacy and whose every breath was about regenerative medicine. His inspiration is driving us to do this CME and workshop in his memory. I welcome the chief guest, Dr. Manish Khanna, who is the great foot and ankle surgeon. He is a professor of orthopedics in Lucknow Medical College, and he has got eminent publications, and he is the founder of the Indian Stem Cell Study Group, a collection of specialists who are practicing regenerative medicine. I welcome you, sir, in spite of your busy schedule, you made this day for us. I welcome Professor Sundararaman, the Principal of National College of Trichy. Thank you, sir, for coming here and giving us this opportunity. This place has been an inspiring place for many students. Many students from Trichy, eminent citizens of India have been students of this college. And it has got a great tradition, and it has completed 100 years of existence. And this year is a special occasion. The Vice President of India graced this college, and he inaugurated the 100th year ceremonies. Welcome, sir. I invite Dr. Ganapati Sundar, who is the President of the Trichy branch of the Dermatology Association. So he is an eminent dermatologist, and he is a chip of an old block. His father was a very great dermatologist, and the father and son duo, a very prominent and very popular dermatologist in Trichy. I welcome Dr. Sendilvel Kumar, my classmate and eminent plastic surgeon from Trichy. Sir, in spite of your busy schedule, you are here to honor us. Thank you, sir. And I welcome the galaxy of speakers here to enlighten us with their vast experience and research findings. I welcome with folded hands Dr. Anil Bansali, the HOD of Endocrinology from PGI Chandigarh. He has been in Chandigarh for the past 33 years, teaching a horde of students, and around 700 publications he has got to his credit, and most of his students are there throughout the world. Welcome, sir. His research on the stem cells for diabetes, which he has been doing for more than 10 years. He has done in vitro studies, he has done animal studies, and then he has done the clinical trial with more than around 100 cases, and we will be hearing his experience in this field of stem cell therapy for diabetes. Dr. Manish Khanna, again one of the speakers, our chief guest, is again a speaker who is going to talk about Shankar Narayanan, who was the inspiration for us. Dr. Pradeep Mahajan, surgeon and researcher for StemRex, he is here to deliver his lecture on the role of stem cells as drugs, stem cell itself as a drug store. So he has got one of the few GMP facilities in India which is authorized to treat stem cells. Not only that, he is a man with the latest technology. He is into the genetic engineering. So with nanochip, he has got technology with a nanochip which is capable of doing genetic engineering. So we will be hearing more about that from Dr. Pradeep Mahajan. Sir, thank you for coming and enlightening us, sir. Dr. Nayana Patel, madam, she is the dynamic gynecologist of Akanksha Hospital, Gujarat, who had been a very close friend of both myself and Dr. Shankar Narayanan. And we had a great association, and she is the first person to do, as far as I know, endometrial regeneration with intra-arterial injection of bone marrow stem cells in India. And she is the queen of surrogacy. She is the queen of surrogacy in India. And we are going to hear a lot about the role of stem cells in infertility from Dr. Nayana Patel. Welcome, madam. Dr. Zahir Hussain of Tosh Hospital, Chennai. So he is the young and dynamic orthopedic surgeon who is showing the way to South India of how to use orthobiologics, using of biological substances for cartilage regeneration, sports injuries. So he has got his training from UK, and he is doing the Kim and Shetty procedure, which is very popular, and more people are taking up this both PRP and stem cells, and it is because of the knowledge which is being slowly spread. And he is now one of the national speakers in conferences involved in orthobiologics. Dr. Professor Manimaran, he is the close associate of Dr. Shankar Narayanan, and both Dr. Manimaran and Shankar Narayanan were pioneers in doing many of the regenerative dentistry procedures. So his studies on OSMF, oral submucous fibrosis and osteoradionecrosis, are the first in the world, and they have got a lot of publications, and I welcome you, sir, for this talk on regenerative dentistry. Dr. Nitya Kalyani is the scientist from the Apollo Transplant Research Team of Dr. Anil Vaidya. So they are planning to start the islet cell transplant unit in India. There are a few islet cell transplant units in the world, but there is no unit in India. So probably we will be hearing and we will be knowing about the possibility of establishing an islet cell transplant unit in India, and she will talk about the challenges involved in starting the unit. Thank you, madam. Thank you for gracing the occasion. And I also welcome all the delegates and all the scientists who have gathered here for the feast of knowledge ahead of us. Thank you.
Thank you, Dr. Ravi sir. Now I request our guest of honor, Principal Professor Sundar Raman sir from National College, to give away the felicitation address.
Dr. Manish Khanna, Chief Guest, Dr. Sendil Kumar, Dr. Anish Bansari, Dr. Ganapati Sundar, Dr. Ravi, Dr. Mohammed Jabir, special invitees, participants, good morning to everybody. Regenerative medicine is a gift of God to humanity. It has the potential to heal or replace tissues and organs damaged by age, disease, or trauma. It is also used to normalize congenital defects. In my school days, I have seen many students with cleft lips. The boys suffered a lot mentally and physically. Our doctors and surgeons have successfully used tissue engineering to repair the cleft lips. Now, it is well known that the problem of cleft lips can be resolved. Imagine the level of happiness and relief it would have brought to the parents and child. Regenerative therapies can cure both chronic and acute problems. Since tissue engineering and regenerative medicine emerged as an industry about 2 decades ago, a number of therapies have reached the market. With the aggressive and passionate pursuit of the concept of regenerative medicine by brilliant doctors like you and the famous dental surgeon Dr. Sankaranarayanan, men and women, especially women, may remain young for long period, if not forever. I am delighted that the event is taking place at our college in association with our biotechnology and microbiology departments. The Department of Biotechnology is one among the best, and the lab and research facilities are of a very high standard. Our Secretary, Sri K. Raghunathan, is taking special care of the department. Dr. Jabir, head of the department, ably supported by his colleagues, is nurturing the department with passion and devotion. I place on record my appreciation to Dr. Jabir and his teammates for the wonderful work. On behalf of the management and the Department of Biotechnology, I thank Maruti Hospital and the Indian Stem Cell Study Group for giving us this opportunity. I wish the program a grand success. Thank you very much.
Thank you, sir. And for our guest of honors, Dr. Sendilvel Kumar sir, Secretary of IMA Trichy. Dr. Sendilvel Kumar sir, Secretary of IMA Trichy. Dr. Ganapati Sundar. And I now request Professor Sundaraman sir to give away the mementos to our respected speakers. Professor Dr. Anil Bansali, Head of the Department of Endocrinology, PGI Chandigarh. Please. Dr. Nayana Patel, Director of Akansha Hospital and Research Institute, Gujarat. Dr. Jahir Hussain, Orthopedic Surgeon from Tosh Hospitals, Chennai. I welcome Dr. Pradeep Mahajan, Director of STEMREX, Mumbai. I welcome Dr. Nitya Kalyani, Senior Scientist, Apollo Hospital, Chennai. I welcome Professor Dr. Manimaran, Head of the Department Oral Maxillofacial Surgery from Tiruchengodu. I request our Chief Guest Dr. Manish Khanna to address the gathering.
A very good morning to everyone with folded hands. I thanks the organizers, Maruti Hospital, the National PG College for arranging such a wonderful CME on behalf of our friend, our pillar for the Indian Stem Cell Study Group, Professor Shankar Narayanan. It's always pleasure to come to Trichy every time, as this is the most pious place I feel in the southern part, more approachable, more dear to our heart. This regenerative science has got a lot of importance which is being expressed, and we are going to entertain it this day, the importance for the mankind. And we feel that this Association of Indian Stem Cell Study Group, with all the legends who are doing the work, all the stalwarts who are doing the work throughout the country, will go a long way, and the light at the end of the tunnel is definitely bright for the future, for the mankind. So I think I should not take much time and just wind up here. Thanking you very much, thanking all the dignitaries who are here, thanking all the speakers, delegates, and especially to Dr. Pradeep Mahajan, who is our pillar. He's with us. Thank you so much. Thank you so much.
Now we'll have a release of the abstract by our guest of honor, Dr. Ganapati Sundar. This abstract contains the protocol of all the research preparations which few of the students would have experienced yesterday in the workshop.
Yes. It's the robo which is delivering the abstract book to the guest of honor.
Thank you, sir. I now request Dr. Natesh Prabhu to give away the vote of thanks.
So good morning all. First of all, a warm thanks for everyone, speakers, delegates, chief guest, everyone. I just want to add one more thing for you. Students, I met Shankar sir 2 years back. பெரிய ஒரு டேர்னிங் பாயிண்ட். நீங்கள் எல்லாம் பார்த்துக்கோங்க. நீங்கள் யூ டேக் அ செல்ஃபி 10 years from now you will feel legacy. உங்களுக்கு தெரியல, உங்களுக்கு லைக் சங்கரனார் யாரும் தெரியாது, உங்களுக்கு என்ன தெரியாது, பட் உட்காந்துருக்கீங்க நீங்கள். பட் 10 years from now you will feel legacy. This is a moment. You can't feel anything now. Learn the concepts. நீங்கள் சொல்லலாம் சார் நான் அதை வந்து படிக்கவே இல்லைங்களாம், பட் learn the concepts. You please try to imbibe that and try to apply that. Being with Shankar sir and being with Ravi sir has changed the whole trajectory of my life. I have to express here, and thanks to the organizers, Dr. Jabi sir and his team, and thanks for our own team like Dr. Avinash Gandhi who was doing all the work, and thanks everyone, thanks speakers, and we hope we have done the best hospitality we can do, and enjoy the show. Thank you.
So we will start the scientific session, sir. The first lecture will be Professor Anil Bansali. All of us are eagerly waiting for this moment. Trichy had the doctors of Trichy, the diabetic club members already had a lecture by Dr. Anil Bansali 2 days back. Dr. Anil Bansali was here on Friday. So Friday night, the doctors of Trichy, the diabeticians, they had a meeting in which Dr. Anil Bansali delivered an excellent talk. Today we will going to listen to his talk on stem cells in diabetes.
So at the outset, I am thankful to Dr. Ravi and his organizing team and Dr. Shankar Narayan for inviting me for this prestigious conference. However, I had an opportunity earlier also, but I could not come here. So this is the first time I have been in a Trichy, a very impressive city. And tomorrow the whole day I was with Natesh for the temples. It was for the whole temple day for me yesterday. So what I am going to talk about the use of stem cells in type 2 diabetes. And in fact the whole idea which we started with this stem cells in type 2 diabetes was our institute started a department of regenerative medicine way back in 2008. And coincidentally this was started by the Department of Nephrology because they had some interest in that, and endocrinology was conspicuously absent. So absence of our department as an integral part of the stem cell regenerative medicine, I think that induced us to do something in this area. And then we explored that what we can do, the use of and utility of the stem cells in patients with diabetes. So when we reviewed, we found that the most of the data available even at that time were in type 1 diabetes. There are only few 2-3 data available, one from Brazil where the Voltaire group was working a lot. There was no data in type 2 diabetes. So what did we think at that time? That because even we didn't have an ethics committee for the stem cells at that time. So we used to have our usual ethics committee. So we just got it cleared over this project because this was only autologous bone marrow derived stem cells. So then we started working on that. And then our stem cell ethics committee was constituted, and then Professor Gongli, who was the chairman of the ICMR also, he was the chairman of our ethics committee. And then the insistence came on the publications, animal work, and a more human data. So we started working on this and we continued to work till 2017, and then we discontinued for a short time. But again, I will show you all our data which we could publish, and we did total around 100 patients of type 2 diabetes who received the stem cell therapy and showed very, very encouraging results. So I think we can have slides. So we have our data from a DCCT, that is a diabetes control and complication trial, and which also showed that these patients were on 4 pricks of insulin a day, and some patients even on the pump therapy, and despite of that they had a problem of having hypoglycemia, hyperglycemia, and only euglycemia could be achieved only 62% of the daytime. So meaning by that, the minute to minute glucose regulation which usually occurs in our body in response to glucose from the beta cell cannot match with the exogenous techniques or exogenous modalities. If you see for that, if your beta cells are replaced or the pancreas is replaced or islets are replaced, then you have a minute-to-minute glucose regulation. You have a reversal of diabetic complications, as has been shown with pancreatic transplant. There is a reversal of nephropathy. The quality of life remarkably improves. The survival becomes better. They are insulin independent for a time, and it's likely to be more and more physiological. Next, please. But even with the islet transplants, the results are not so encouraging. You can see that the first year independence of insulin is observed in 3/4 of the patients. But with a duration of 5 years, only 10% of the patients are insulin independent. Rest 90% of patients, they do require insulin. Meaning by that, this islet cell transplantation, they do also die their natural death, or they do also die despite being on immunosuppressive therapy, the cells get destroyed. In addition, immunosuppression has got many problems as an adverse events, which includes local bleeding, portal vein thrombosis, mucositis. And there is a progressive use of antihypertensive medications if you use immunosuppressive therapy for these patients. Next, please. However, the patients with type 2 diabetes, they make a bulk. 95% of the patients even in our own country and globally also, they are patients of type 2 diabetes, while only type 1 diabetes contributes only 5% of the total patients. However, and we all know that the two characteristic defects of type 2 diabetes is insulin resistance and insulin deficiency. Next, please. However, with a better understanding of the pathophysiology of a disease, now there is called as an ominous octet, means 8 pathogenetic mechanisms have been elaborated to understand the pathogenesis of a disease, where you can have involvement of alpha cell, beta cell, you have even brain is also involved, the muscles glucose uptake is reduced, even kidney is also involved, and you have got a involvement of the liver as an increased hepatic glucose output. If you see for that, even in type 2 diabetes, as I mentioned, insulin deficiency is a characteristic feature, and even a diagnosis, almost 50% of the beta cell functions are lost even at diagnosis. So meaning by that, in type 1 diabetes, as I mentioned, insulin deficiency is absolute, while in type 2 diabetes, you have got a relative insulin deficiency, so means they also do require insulin replacement, some or in other form. This is about the insulin resistance, another component which I showed, and you can see that insulin resistance fairly remains constant after the emergence of hyperglycemia. This is a beautiful study called the Belfast Diet Study, and where it was very clearly shown that the insulin resistance showed in a panel B, that is a HOMA S, and you can see that it's almost fairly constant, while if you see in a panel A, that is a HOMA beta, and HOMA beta progressively declines, and you require addition of drugs with advancing duration of disease. So meaning by that, the beta cell functions goes away even in type 2 diabetes. Of course, the course of decline in beta cell function is slow, it is smoldering, while in type 1 diabetes, it is very, very fast. So, what are the drugs which really maintains the beta cell function in type 2 diabetes? So, intensive insulin therapy, which many patients may not like. The glitazones definitely has got a better effect on beta cells, but it also causes fracture, and it also causes more problem related with the bladder cancer. The GLP-1 analogs are injectable, they are very, very expensive. The DPP-4 inhibitors, only data are available in mice to show the improvement in beta cell function. And last option remains is you should talk for a beta cell replacement therapy even in type 2 diabetes. So these are the different modalities which we have. You have an option for a pancreatic transplant. The source is being cadaver. So after the brain death, our cadaver's pancreas is taken out, and currently this is used in clinical practice like our institute does. You have the probability of an islet transplantation, but you require the 4 pancreas for one patient. So 3 to 4 pancreas are required for one patient. So means the 3 donors should be available. Either they may be a post-accident or they may be post-brain death. The theoretical possibility of a beta cell transplant, yes, it always remains, but still it is much experimental. And so the stem cell therapy gives an option that you can use these progenital stem cells and they possibly might have a promising future even in patients with type 2 diabetes. So what are the stem cells? So given this background, type 1 diabetes certainly are the best candidates. Type 2 diabetes are really potential candidates for stem cell therapy. So these are the cells which are capable of both self-renewal and differentiation into at least one mature cell type. And our hypothesis is this, that they colonize to injured tissue due to prevailing cytokine milieu that we call as a homing in. Even we give these stem cells directly intravenously, some of the stem cells will home into the pancreas because pancreas is an inflammatory state in patients with diabetes. There are types of stem cells, toti, pluri or a multipotent, and usually we are talking mainly of a multipotent stem cells because with the totipotent stem cells, particularly like an embryonic stem cells, there are some concerns like development of an teratocarcinoma or embryonal cell carcinoma, and that's why the safest and even our ethics committee do not allow the use of these types of cells. So the most preferred cells which ethics committee usually gives the permission, it's an autologous bone marrow derived stem cells. I think there is a problem. You go with yes. So this is the first data from our own country published by Meenal Banerjee way back in 2005 and showed that this is data in a mice where the diabetes was induced by streptozotocin. You can appreciate in a panel A, these are the normal islets which is shown here as an arrow, and these are the quite big islets. So once these mice were made diabetic by after giving streptozotocin, then they were injected the same stem cells transplant in these mice, and after 6 weeks of the therapy, you are finding the generation of these smaller new islets. So that was a point. Yes. So you can see that the new islets were generated after injecting the stem cells in these mice through the red tail vein. Then again it was a very interesting, the first data from Brazil came where in patients with type 1 diabetes who are really the ideal candidates for the stem cells showed the very encouraging results. And you can see that the 14 out of 15 patients, they became insulin free, and hemoglobin A1C could be maintained less than 7% in out of these 13 out of 15, and you can see that it was highly appreciated as the C-peptide response was remarkably improved from pre-transplant at 24 months, means at 2 years, up to 4.5 nanogram per ml. However, the Voltaire had a demise few years earlier. He could publish the follow-up data, but again it showed a progressive decline in the efficacy of the beta cell function with the passage of time. So meaning by that, they do die their own death, and even the stem cells which you infuse into the pancreas, here it was given intravenously, even they go to the pancreas and they also die their natural death because of the immunoinflammatory restriction of beta cell. So why did we choose in type 2 diabetes? Because they are the major chunk of the people who contributes to the diabetes globally. So here in India, even we have a data of around 95% of the people with type 2 diabetes are there. They do have a progressive beta cell failure. However, the process is slow and no immunosuppression is required, because none of the ethics committee will easily give a permission in a patients with type 1 diabetes where you knock down the immune system by giving immunosuppression, and they become very prone for secondary infections. And usually in a government sector, the secondary infections are not uncommon, they are quite common, and if any child with a type 1 diabetes dies because of this procedure, it will be very, very alarming. So we thought that in type 2 diabetes, we do not require immunosuppression. And they do also have a progressive beta cell failure. Why we should start with type 2 diabetes? So the whole idea came way back in 2007. And when did we start this process? So a few days prior to our publication, in fact, when we started exploring the literature, there was no data, but only this study came which we found, and this was published 2 months prior to our study. And what they did, they used a combined treatment of intrapancreatic. Directly the stem cells were injected into the pancreas. I will tell you how they did do that, because we also did in a similar way. And they used an hyperbaric oxygen. The hyperbaric oxygen, if you use during the administration of stem cells, they also direct the flow of the stem cells to the inflamed tissue. So they also help in homing in of the stem cells into the inflamed tissue. And however, this study had some fallacies. Number of patients were 25. Duration of study was only 1 year. And 82% of the patients, they did respond, means they had an improvement in hemoglobin A1C. But the major flaw of the study was that the 2/3 of the patients were lost to follow-up. So that's why they could not make a long-term follow-up of these patients. This was a decline in hemoglobin A1C, and you see that initially started with 25 patients, and finally we had only 9 patients, but they had a drop in hemoglobin A1C which was quite significant. However, because the study we did not find at that time, because it was just published 2 months prior to that. So by that time we had already derived a protocol what we should use. So this was an autologous bone marrow derived stem cells in patients with type 2 diabetes, and we made a very stringent criteria. So that gives the first outline globally, that after that many studies have come and they have followed almost our inclusion and exclusion criteria. So here this was only 10 patients were taken initially as a pilot project and open label interventional trial. So we took a diabetes who are already having a disease of more than 5 years, and they are already having a failure of the triple oral hypoglycemic agents, and they were on a quite good dose of insulin requirement of 0.7 unit per kg per day. So in fact they were having a very advanced duration of a disease, and we just wanted to see that by giving stem cells in these patients, do you really have any benefit? They were on stable doses of insulin, metformin and pioglitazone for the past 3 months, and these were the exclusion criteria of these patients. So baseline parameters of these patients were, 8 were men out of these 10. The mean age was around 58 years. You can see the duration of diabetes was 15 years. So it was a long standing duration of a disease, and we presume that by that time their beta cell functions have remarkably lost. The mean duration of, they were already on insulin for 5 years. Their mean dose of insulin, you can see that they were requiring around 70 units of insulin per day in divided doses. The mean BMI was around 27 kilogram per meter square, and they were centrally obese. As we all say that Indian diabetics are centrally obese, they do have a abdominal obesity. So they had a mean waist circumference of 93 centimeter. This is how the bone marrow was aspirated. We aspirated the bone marrow from the iliac crest, and around 100 to 150 ml of the bone marrow was aspirated. Most of the patients require only unilateral exploration. However, those people who are older and osteoporotic, they require a bilateral exploration. And after this, the cells were counted. They were separated by the Ficol gradient. We did the immunohistochemistry with the CD34, find out what are the number of the hematopoietic stem cells, and finally a 10 ml of the concentrate was prepared of these mononuclear stem cells, and they were injected directly into the pancreas. Then the next question comes whether we should give intravenous or whether we should give local. What happened that because even in a Volteri study in type 1 diabetes, they gave intravenously. We had a just idea is that why not we should give intrapancreatically so we can have a better localization and access of the stem cells to the pancreas. So we chose to give through the celiac trunk, and our intervention radiologist, it approached and they went up to the superior pancreaticoduodenal artery, which supplies the head and part of the body of the pancreas and comprises almost around 2/3 of the beta cells in the normal pancreas. So we presume that the home of the beta cells is basically in the head and the body of the pancreas. So why not we should inject these stem cells directly into the pancreas through this superior pancreaticoduodenal artery. Then how did we define our response? When we'll say that stem cells are really effective? So we made certain criteria, and criteria was very stringent. We just wanted to show that like their insulin requirement was 70 units per day, it should come down to by 50%, that means around 35 units per day, by even with maintaining a hemoglobin A1C below 7. So that was a very stringent criteria, and another endpoint was C-peptide response to glucagon. In addition, we had a secondary endpoints like hemoglobin A1C, insulin glucose homeostasis parameters. The 7 patients responded. Time frame was different. I will tell you that how much time they take. Usually by the 3 months, most of the patients they responded. So means the 7 patients could maintain hemoglobin A1C below 7 even with a reduction in insulin doses by 50%. So you can see the data. The insulin requirement came down from 70 units to 28 units. They were mostly on the 2 pricks rather than 4 injections a day. The fasting plasma glucose came down. The hemoglobin A1C came down significantly from 8.4 to 7.3. The stimulated C-peptide was risen up. HOMA beta also improved, and there was no change in insulin resistance in these patients. However, and this is a graphical representation, those patients who responded, you can appreciate the C-peptide change from 1.2 to 2.25. Those who did not respond, it was a flat response, and this was the HOMA beta, that is a marker of the beta cell function. It improved with those who responded to the treatment. No adverse events except we had some problem with the vomiting in one patient. We had an injection site hematoma in one patient, and there was a drop in hemoglobin because we took around 150 to 100 to 150 ml of the marrow. So there was a drop in hemoglobin which gradually improved. And another qualitative improvement which we found was that the number of events of hypoglycemia were remarkably reduced. Meaning by that, there was some rejuvenation or a kick to the residual beta cell function. That's why the glucose control became very smooth after the injection of stem cell. However, we did not do continuous glucose monitoring to show that the glycemic variability is reduced, but certainly the hypoglycemic episodes were remarkably and significantly reduced. However, there was one issue with this, our first study, because one of the reviewer, when we published this paper, he definitely told us is that because your patient lost around 3 to 4 kg of body weight, and this loss of body weight may be directly related to the decrease in insulin rather than stem cells. So he even used the word, your stem cells are like placebo. Because if you lose the weight, because these patients were coming very regularly to us, we were giving them instructions for dietary restriction and lifestyle modification. So they lost around 3 to 4 kg body weight. So they asked that this may be just as the stem cells may be placebo. However, we gave an explanation that the weight loss was a later event, reduction in insulin requirement was earlier. But we also had some question in our mind, so we have to prove it. So then we did a second study, which we published in Cell Transplant. Here we took 2 groups and we injected saline in one group and we injected stem cells in another group. So you see that even in a saline group, there was an initial benefit. However, the benefit could not be sustained for a period of 1 year. We attributed this initial benefit to the saline was mainly because whenever you call the patient so frequently, you interact with them, you insist and endorse with the insistence on lifestyle modifications very sincerely, they do it, but it is not sustained even for a longer time. So you can appreciate that the change in a hemoglobin A1C showed in a change in a weight and insulin dose in a placebo group or saline group, hardly there was any change. But you can see that patients who received this, there was a change in insulin doses and there was no change in weight. If you look for a hemoglobin A1C, yes, there was an initial decline, but then it went up to rise in group 2, that is the saline group, while in a placebo group, it continued to fall. If you look for a C-peptide response, it was a flat in group 2, that is a saline group, while in group 1, that is a stem cell group, there is a progressive rise in C-peptide, followed by later decline after some time. So meaning by that, the stem cells were in fact not the placebo, they had some effect which lasted at least for a period of 1 year. Then our ethics committee further asked, because by this time the paper was published, but they asked, you must do the animal studies. So without animal studies, we didn't have any mechanistic insights how these stem cells are functioning. So then we had one PhD student and he started working on that. So this was the shown on this mesenchymal stem cell transplantation. This was a mesenchymal stem cell transplantation obtained from the mice, cultured and injected after the streptozotocin induced diabetes in these rats. The panel A shows the hematoxylin and eosin staining, and you can appreciate in an experimental group the development of the newer islets. This is further shown in a panel B, that is shown by the arrows, the development of the new islets. And the panel C is basically by the immunohistochemistry. You can see that, however, it is quite faint here, but you can appreciate there is some formation of a new insulin granules on immunofluorescence. And we again did this. So we labeled these cells with a BRDU, and we wanted to know that are these cells really going into the pancreas or not. We could identify these cells because the BRDU also could be observed into the mice where the stem cells were injected. So meaning by that, these stem cells really went into the pancreas of the mice. So we could demonstrate that there is a BRDU is shown along with insulin. However, we could not prove whether this was a transdifferentiation of the stem cells which we injected, or it was just as a fusion of the stem cells with the existing beta cells. So mechanistic insight studies are still required. We did not fulfill the really how these cells are acting. We proposed some views at how they are acting, but we could not prove that. We only could show that the cells goes into the pancreas. They may transdifferentiate or they may fuse with the beta cell, and they may give a kick to the residual beta cell, so the beta cell functions improves. So this was on electron microscopy, and we could show that there is a formation of the secretory granules indicating endocrine differentiation of these islets. Then we did another study to have a mechanistic insights, not for the stem cells, but how they are acting and how they are improving the glucose homeostasis or a glucose control. So here what we did the autologous bone marrow derived as well as the mesenchymal stem cells. We took the both. The mesenchymal stem cells, when you take a hematopoietic stem cells from the marrow, the mesenchymal stem cells contributes only less than 1%. So we took these mesenchymal stem cells and cultured in vitro. And these cultured mesenchymal stem cells were injected in one group, another group was given the bone marrow derived hematopoietic stem cells. So we had now two sets of the cells, one was a mesenchymal stem cells and one was the bone marrow derived stem cells. And what we could show, there was a difference in the two. If you see the panel C, fasting C-peptide there was no change with the mesenchymal stem cells. However, AUC of the second phase we did by the CLAMP study, which is considered as a gold standard to assess the beta cell function. There was a significant change with the AUC of the C peptide. And so meaning by that, the hematopoietic stem cells, it is wrongly written, I think I'll tell you, it is a hematopoietic stem cells significantly improves the beta cell function, while the mesenchymal stem cells improves the insulin sensitivity. So you heard two mechanistic insights. If you use an autologous bone marrow derived hematopoietic stem cells, they are preferentially acting on beta cell. If you are using a mesenchymal stem cells, then you have a remarkable improvement in insulin sensitivity because it upregulates the IRS1, that is the insulin receptor substrate, that mediates its action through post-insulin receptor signaling pathway. If you go further, I mentioned that we injected stem cells directly into the pancreas. We were very happy. We thought that all the cells may be going there and pancreas is getting regenerated, but it all hold untrue. So what we did, we started labeling these stem cells. So we labeled with FDG PET. So FDG PET is a fluorodeoxyglucose, and we did a PET scan every 4 hourly. And we looked at where these really stem cells are going. So if you see that, this was a infusion of the stem cells through superior pancreatic artery, means directly into the pancreas. You can see in a panel A, this bright spot which you see at the site of the pancreas. Yes. So this is the localization of the stem cells. This is the localization of stem cells. Rest of the cells are going to the liver. So we could demonstrate the cells which are injecting. But when we quantify these stem cells, they were contributing only 3 to 4% of stem cells. So like we injected millions of stem cells, but only 3 to 4% of stem cells really could be held in the pancreas. When we injected in these stem cells, this was work done by Dr. Sood, who came last year here. So when we, because one patient had earlier gallbladder surgery, so his superior pancreatic artery was distorted because of the anatomical alterations. So this was injected through splenic artery, and again you can demonstrate there is some cells present into the pancreas. Again the contribution is only around 3 to 4% of stem cells. Then if you give intravenously, because as like Voltaire many people give, you did not localize any stem cells in the pancreas. So certainly when we give directly into the tissue which is inflamed, which is diseased, you have a more number of stem cells. However, the quantum of the stem cells is very meager. But I think even the meagerness of these meager stem cells or meager quantity of stem cells possibly still contributes to improvement in residual beta cell function. So this, what happens to the rest of the stem cells? They go everywhere. You can see that they are found in a brain, they are found in a liver, they are found in a lung. They are all destroyed by the reticuloendothelial system. So there is no harm. It's a patient's own stem cells, and the reticuloendothelial system kills them. So this was again a follow-up of data of our patients, and we showed it is a 15 months follow-up only. So we are now following these patients again vigorously. What is happening to these patients? The total number of the patients, we have done something around 90 plus. So we published around 55 patients, including Dr. Vikas Sood, who was our colleague. So now we publish the whole data. But here, even at a 1.5 year, the 6 out, like initially 7 out of 10, the 6 out of 10 continue to maintain their reduction in insulin requirement, and they were still responding very well. So this is the total literature available in the world. So our contribution is really 4 out of these 7, 8 papers or 10 papers, we have got a contribution here. So at least I will still share with you that the mechanistic insights we do lack, number one. We also have to work out the number of stem cells we inject. And what did we find in our first study? Higher the number of stem cells, greater is the response. So what is the mechanism? These are the proposed mechanism from the literature. Only one point which I have added, the transdifferentiation, that we hardly could demonstrate, but we propose the two theories. Either they may transdifferentiate into beta cell or they may fuse with the beta cell and may induce them. Other mechanisms includes, because whenever we inject these mononuclear stem cells along with hematopoietic stem cells, they do have a lot of growth factors. And these growth factors may lead to angiogenesis. They may upregulate the transcription factors which were involved in the embryogenesis of pancreas, that is called PDX1. They may promote the growth and differentiation of beta cells from ductal epithelial cells. You remember that endocrine pancreas means beta cells developed from the exocrine pancreas. And exocrine pancreas means it is from a pancreatic ductal epithelial cells. They do differentiate into the endocrine cells. Initially we believed that the beta cells, they do die with the time. They do die with the aging. But now they say the beta cells grows throughout the life. Even sometimes those who are diabetic, the beta cells in fact convert to alpha cells. They differentiate into alpha cell, rather they prefer to remain in a beta cell. So that's why the initial myth and belief was that beta cells are not immortal. I'll say beta cells are mortal, that yes, everyone is mortal, no doubt. But the beta cells, they do transdifferentiate to alpha cell, and they reconvert again back to beta cell. That happens with intensive exercise. If you do an intensive exercise program, and you must have heard about the intermittent fasting nowadays, which is an ongoing concept for preserving the beta cell. You give a rest to the beta. They say, even I presented one talk, that the title of the talk was, the beta cells are the essence of life. If you have a preserved beta cell, and if you do not develop diabetes, insulin is a hormone, we always say that which keeps you fat. No, insulin is a hormone which keeps you thin. If you have insulin resistance, then and then you become fat. Insulin is a vasodilator. Insulin has got an effect on endothelial function. So insulin is, I think, one of the most potent anabolic hormone and most potent vasculoprotective hormone. Because aging, why the people die? The people, you leave aside accident and malignancy, leave aside, but the people die mainly because of vasculopathy. You have got a vascular involvement, that's why the blood supply to each organ decreases with aging. And that's why the aging, the organ starts function declining, but the insulin is a hormone which maintains the vascular health as well. So that was the reason for that. We thought they are possible, but certainly we do require more work to understand the mechanic insights of the stem cells into the pancreas. But what do we need? We really need this. Whatever the work which I showed, autologous bone marrow derived and fine, you have to do it possibly repeatedly every 3 years, 4 years to sustain it. But I think you require this. What do you require? You require the development and differentiation of the beta cells in vitro. So you have got a pluripotent stem cells which are OCT4 positive, then differentiation into definitive endoderm, pancreatic progenitor cell, endocrine progenitor cell, and beta-like cell. Then you dissociate these beta-like cell, you re-aggregate with the other type of cell. I'll tell you there is one difference in mice and the men. In a mice, the beta cell, even if you develop, grow in vitro and inject, they do function very well. But if you make the same beta cells inject into the men, it does not work. So beta cells only work when they are compounded with the other surrounding cells. So you need so much of bunch of cells. You need the beta cells, you need the hub beta cell which produces insulin, you need the other endocrine cell, alpha, pancreatic polypeptide, delta cell, we need the stromal cell, we need the neural cell, we need the, that's why even the people, those who are working exclusively on the in vitro differentiation of adipocyte or hepatocyte into beta cell, they are not able to succeed. One thing, because we have understood that the beta cells in isolation do not work in men. They do require the presence of the whole islets what the God has made. Mice is an exception where the beta cells work in alone, in isolation. So we are the exception, we are not the mice. So certainly we require more and more work in this area, and possibly I think the future is pregnant with many possibilities. So it is not the end that we have shown this data, it is not functioning for a short time, but I think the scientists will definitely make this type of development of these islets from this and eventually a time will come when you will have the whole dream as a beta cell transplant or beta cell stem cells like that. So to conclude, the stem cell therapy can be an effective as a safe and possibly, it's a safe because it's autologous bone marrow derived. It's effective means it works for definitely for 3-4 years. Certainly we have more data to show that how long really does it work. The predictors of response we could identify from our 2 studies, the baseline level. If the baseline beta cells are good, they do work very well. And MNC dose and insulin requirement. Those who are requiring lesser insulin, they do respond better. Suppose you take a patient who's never on insulin, they will do much better. And lastly, efficacy of the stem cell therapy is ill-sustained and requires further exploration. So I think that, so this area is to be evolving area has to be developed and has to be further explored, more mechanistic insights and more aggressiveness by our society, and I think the people will do that, and hope you would have enjoyed this lecture, and thank you for your patience hearing.
Thank you, sir. Thank you. It was an excellent lecture. I request Dr. Pradeep Mahajan, sir, to give the memento and the medal, gold medal, the oration medal also.
By Dr. Anil Bansali. Next, we shall have an audio visual about Dr. Professor Shankar Narayanan. It's about his journey through the regenerative medicine and the aspects that he has introduced in dentistry and other systemic diseases as well. So, we shall have a look upon the audio visual about Professor Dr. Shankar Narayanan.
Shankar Narayan. I am basically a dental surgeon, specialized in oral pathology, and we are doing stem cell research for the past 9 years, from 2008 onwards. My company's name is Mother Cell Regenerative Center. We have focused stem cell application particularly about the dental and oral diseases and application of dental pulse stem cells in others. நான் பிறந்து வளர்ந்து படிச்சதெல்லாம் பரமத்தி வேலூர்ல தான். அதுக்கப்புறம் பல் மருத்துவத்துறையை சென்னையில முடிச்சுட்டு எங்க பிராக்டிஸ் பண்ணிட்டு இருக்கலாம் அப்படின்னு தேடும்போது அப்ப திருச்சியில பணியாற்றக்கூடிய வாய்ப்பு கிடைச்சது. Topic is going to be a new entity now, even though it is in an infant stage, it's going to be future of medicine. We have been working here in this city for the past 1 decade, more than 1 decade, and we are only few members in this group who have done about this work of regenerative medicine. We are going into a new concept of a treatment management, which is never seen in medical industry. Right? Regenerative medicine is the process of replacing or regenerating human cells. This is for hair regeneration, mainly in youngsters. So we start injecting this PRP, both autologous and allogenic. We encountered a case, the 50-year-old retired bank officer. He gave voluntary retirement because of his movements. He was not able to sign his documents. Stumbling, there was buckling of the knees, and his ankle was hitting with each other, and he used to fall down. We contemplated on giving stem cells for the patient. Dental pulp stem cells derived from dental pulp, and intrathecally, that is through lumbar puncture, and also intravenously, and the patient progressed. Was studied after a month's time, and the patient's movement in the leg was 90% better, but the head and neck shoulder movement was 10% better, but no improvement in psychiatric symptoms. Leave the school teacher parent. டீச்சர் பேர் என்ன? மீனாவா? அம்மா பேர் என்ன? பாப்பா அம்மாவா? அம்மா பேரு அப்பா அம்மா பேர் என்ன? பாப்பம்மா தானா? This is a condition which is pertaining very commonly in India, particularly in the Asian part of the world, where people, because of chewing pan parak, you get Christmas. The patient cannot open the mouth and they will develop malignancy. 50,000 people every year getting malignancy because of this. This is a condition which I have treated for the first time globally and presented this in 2008 in US, in Philadelphia. ஓரல் சப்மியூக்கஸ் ஃபைப்ரோசிஸ்ங்கிற இந்த நோய் வந்து தமிழ்ல வாய்மூட்டு நோய் அப்படின்னு சொல்லுவோம். புதுசா ஸ்டெம் செல் சிகிச்சைங்கிறத அறிமுகப்படுத்தியிருக்கிறோம். இந்த ஸ்டெம் செல் சிகிச்சையில பேஷண்டோட இடுப்பு எலும்பிலிருந்து ரத்தத்தை எடுத்து அந்த ரத்தத்தை சுத்திகரித்து இந்த வாய்மூட்டு நோய் ஃபைப்ரோசிஸ் ஆயிருக்கிற இடத்துல நாங்கள் இன்ஜெக்ட் பண்றதுனால அந்த இன்ஜெக்ட் பண்ற இடத்துல புதிய ரத்த நாள சுரப்பிகள் அதிகமாகி அந்த வேறுபட்ட ஃபைப்ரஸ் டிஷ்யூவெல்லாம் நார்மலா மாறக்கூடிய வாய்ப்புகள் கிடைச்சு அந்த பேஷண்ட்ஸ் யாருக்குமே கேன்சர் வரல, இது வரைக்கும் வரல. அதே மாதிரி வாய் திறக்கிறதும் உமிழ்நீர் சுரக்கிறதும் ரொம்ப சக்சஸ்ஃபுல்லாகவே இருக்கு. இது வந்து மேற்கொண்டு ஆராய்ச்சிகள் செய்து இதை விரிவுபடுத்தணும்னா இந்த நோயை தடுக்கக்கூடிய வாய்ப்புகள் நமக்கு. I will just show you how histopathologically we have proved the new angiogenesis. This is the epithelium, this is the connective tissue where you don't see big blood vessels, number one. Number two, a fibroblast, if you see, it is supposed to be wavy in nature, isn't it? So here if you see the fibroblast, the collagen fibers, fibroblast are very flat. Morphologically, biochemically it has changed and there is no blood vessel. The fibrosis is because of the compromised vascularity and morphologically the structures which are different. After our injections, you can see improved vascularity, new blood vessels are being formed. We have also proved that immunohistochemistry and reduction in the inflammation. This is the first time we have shown that the fibrosis is being reversed and you can see the wavy pattern of the collagen.
He treated a case of odontogenic keratosis where every plastic surgeon or an oral surgeon said, "We'll have to chop, cut, take out." But this man was the only person who said, "Let's regenerate, let's regrow." Today, after 2.5 years of stem cell therapy, each cell stands there like a rock.
These are the mandibular reconstructions of this ameloblastoma. I showed that in the mandibular tumor itself without resection, we have proved the stem cells have got anti-tumor property for particular type of tumors. One among them is this ameloblastoma. So culture in our lab proved that it has got anti-tumor property and then it is being applied in the patients. நாங்க செஞ்சிருக்கிற இன்னொரு ஒரு ஸ்டெம் செல் சிகிச்சை, சில பேருக்கு கேன்சர் வந்துச்சுன்னா அந்த கேன்சர்ல வாயில இருக்கக்கூடிய எலும்புகள் கெட்டு போக வாய்ப்பு இருக்கு. கதிர் இயக்கம் இரேடியேஷன் கொடுத்தா அந்த மாதிரி கெட்டு போற எலும்புகளை இதுவரைக்கும் வெட்டி தான் எடுத்துக்கிட்டு இருந்தாங்க. தூக்கி போட்டுருவாங்க, கட் பண்ணி சர்ஜரி பண்ணி வேற எங்கிருந்தாவது எலும்பு வைக்கணும். அந்த மாதிரி கட் பண்ணாம அதை இந்த ஸ்டெம் செல் மூலியமாகவே நாங்க சிகிச்சை செஞ்சு அதை காப்பாத்திருக்கோம். அதை அமெரிக்கால ஆண்டர்சன் இன்ஸ்டிடியூட்ங்கிற சென்டர்ல இருந்து நம்மளுடைய செயல் முறை விளக்கத்தை அவங்க வாங்கியிருக்காங்க. அவங்க அதையே பயிற்சி செய்யறதுக்கு உதவி செய்யறதுக்கு ட்ரை பண்றாங்க அவங்க நாட்டில்.
To a common man, periodontal regeneration is something that means it is gum infection. This case is a case of a periodontal bone regeneration where there has been severe loss of bone in all the teeth, so there is no support to the tooth. And the only way to do that is to extract off all the teeth, but the answer was different. We regenerated autologous bone, and in 6 months you can see the amount of bone regeneration that has come. And when the bone is holding the tooth becomes stronger, so you do not need to extract a tooth. The answer given by Dr. Shankar Narayanan can be very cleanly seen in the intraoral x-rays, where in the first one, the pre-op, you can see that there is absolutely no bone on the tooth, but the same tooth post-op after 6 months, you can see that there is bone regeneration and it is being held strong.
Revascularization revascularization with PRP. Revascularization is the procedure to re-establish the vitality in a non-vital tooth to allow repair and regeneration of tissues. It can mobilize cells from periapical region. In this case, we remove necrotized pulp tissue from immature permanent tooth. Then, triple antibiotic paste placed in canal for 3 weeks. After 3 weeks, bleeding induced inside the canal and PRP injected in one tooth, and in another one, PRP only injected. RBG taken after 3 months shows root formation. After 1 year, there is a complete root formation in PRP injected teeth. In this video, we can able to see that the patient responds to heat stimuli, which shows the tooth become vital after 1 year. Hence, revascularization with PRP will enhance the root formation.
These are the things which when we went to China, where we had an international contact of this stem cell association. When Dr. Cherian visited our place in our lab, when we showed about this submucous fibrosis, he immediately thought that it will be very useful when post-surgery, cardiothoracic surgery, when there is a sternal wound infections or when there is a fibrosis, it can be prevented. They have already done about 10 cases. They injected this lyophilized PRP only and they get some improvement. At least there is no fibrosis. We have regenerated endometrial problem. We have improved the sperm count after this injection for a case of an oligospermia from 3 million to that of 80 million. It is intra-articular injection done by Dr. Ravi.
மறுபடியும் கார்ட்லேஜை ஓரளவுக்கு வளர வைக்க முடியுமா, அதற்கான முயற்சிகள் தான் இப்போ நாங்கள் எடுத்திருக்கிற பிளேட்லெட் ரிச் பிளாஸ்மா மற்றும் இந்த ஸ்டெம் செல்ஸ். உடம்புல எல்லா உறுப்புலையும் கொஞ்சம் கொஞ்சம் ஸ்டெம் செல்ஸ் இருக்குது. ஆனால் ஈஸியாக எடுக்கக்கூடியது போன் மேரோவில் ஒரு ஊசி போட்டு மஜ்ஜையிலேருந்து எடுத்துடலாம். அதே மாதிரி ஃபேட்லேருந்து எடுக்கிறது ஈஸியாக எடுக்கலாம். அது மாதிரி எது நம்மளால் ஈஸியாக எடுக்க முடியுமோ அதை எடுத்து இது மாதிரி அந்தந்த உறுப்பை ரீஜெனரேட் பண்ணுறதுக்கு, ஆர்த்ரைட்டிஸாக இருந்தால் கார்ட்லேஜ் ரீஜெனரேட் பண்ணுறதுக்கு நம்ம யூஸ் பண்ணலாம்.
What we are trying to do is new angiogenesis. New blood vessels are formed. By getting this new vascularization, you get blood circulation gained in that area. We have given dental pulse stem cell first time in India, where the allogenic dental, like the kid when they come for extraction, I say that culture the stem cells and give it for various applications. The stuff which is not being healed, post of 1 month and post of 6 months. The dental pulse stem cells are unique and very useful for 2 reasons. It has got more angiogenic capacity. Number 2, it has got neural regeneration. No other stem cells in our body has got ectomesenchymal origin by embryologically. So this stem cells has got both neural regenerative capacity and more angiogenic capacity. Platelet-rich plasma, we have modified and we call it as platelet lysate. The platelet lysate has got almost similar type of properties to that of stem cells itself, which is very, very astonishing, very useful. And second thing is, what we have done is, we have not taken fresh platelet. We found out lot of platelets in our blood banks are wasted or thrown out without using. So what we are taking is unused platelet after the 7th day. As all of you know, 5th day or 6th day they discard the platelet. So take the blood bank platelet only after the 7th day, and we have properly brought it. Technology is being developed in Trichy, and we have developed this process is called platelet lysate. To improvise the stability to use it, we have made it into a lyophilized form, which has got antibacterial effect. As you said, your resistance can be combated here by not using your regular antibiotic or more antibiotic. Eventually, this PRP will help you to, even in your resistant cases, and particularly it is very useful in your Staphylococcus aureus. Here in India, in Trichy, where this is our lyophilized PRP product, which can be applied topically like this, or it can be diluted and it can be either injected into the wound bed or in the margin, or it can be dissolved. I am very proud to tell you, both myself and Ravi, because of our research on PRP, we have submitted a project to the Defense Ministry, where our project is being approved soldiers in war front, they will be in a very advanced state, upfront, where to come down from a terminal, that war area, suppose they get a bullet injury, to reach there in about 3.5 hours or 4 hours. By the time, because of bleeding, they die. And that area, you don't have FFBs or replacement. So what we have done is, from the blood bank, we take the FFB, we pull it, and then lyophilise. So all the soldiers can carry this, and they have to just dilute this with a normal saline, and it can be given. So we have submitted, and that is why she has immediately accepted this project, and she has asked us to submit to the Defense Ministry, and we have sent it to the Defense Portfolio, and they have accepted. Once we get approval from the DCGI, our product will be submitted to the Defense Ministry from Trichy. First time we will be supplying this very important life-saving to the soldiers.
Plasma, platelet matter. I can't imagine the Defense Ministry coming up with powdered plasma acceptance of necessity. Today that immediately makes me think I would go back to Delhi and immediately ask our Armed Forces Medical Group to contact you, get something, test drive. And after that, who's going to manufacture? அந்த டைப் கூட பண்றதுக்கு என்ன பண்ணணுமோ அவங்க கிட்ட உடனே சொல்றேன். பிகாஸ் இதுல ஹை ஆல்டிடியூட்ல எப்படி இருக்கும், கேன் ஐ மிக்ஸ் இட் அப் வித் தட் IV fluid in the high altitude area? If not, where do I get it? What will be the shelf life after I make it into liquid? இதெல்லாம் அவங்க, they should be the people to apply their mind and also use it and try it.
Of course, we have also written a book on stem cells. This is the chapter which I have written about the stem cells in a dental book. And these are the publications of about 10 publications exclusively on regenerative medicine. Our name is being referred in many books and journals because of our publication.
Professor Dr. Stem Cell Shankar Narayan, he's in his own league as a dentist, as a scientist. This man was the only person who said, let's regenerate, let's regrow. For those people who don't know him, his work will stand as a testimony. For those lives he touched, his passion he has left for us, we will feel it every day as a wow factor.
Thank you. The purpose of this video is not just to showcase who Dr. Shankar Narayanan was.
Good morning, everybody. At the outset, I would like to congratulate the team in Trichy under Dr. Ravi and Mrs. Shankar Narayan for organizing this conference and giving me this opportunity to pay my tribute to him. I met him first June 2016 in Delhi for a conference, and then we started when I was not knowing what was stem cell and how it can be used. And in such a short span of 2 years and few months, he made me do all this, and sincerely I pay my tribute to him. My best luck to his dynamic daughter, and I'm sure she's going to fulfill her father's dream. All the best and God bless you. Without wasting time, I will now go to the topic of PRP and stem cell therapy in infertility. 1 in 6 couples suffer from infertility, and it's definitely on a rise for various problems from sperm disorders to ovarian dysfunction to blocked tubes and uterine problems. The various treatment modalities now available are intrauterine insemination, test tube baby. If there are no gametes, then donor egg, donor sperm, donor embryo, and if the uterus has an issue, surrogacy. Then what is the need for the new treatment in infertility? Well, both men and women, when they are told that you will need a donor gamete to have your own child, it's like a big no. They want to use their own genes, their own reproductive material to see their next generation. And also when you tell them that your uterus is really bad because of tuberculosis or fibroids or adenomyosis, they would really want to not go for surrogacy. Well, stem cell is not an answer to all this problem, but majorly yes to many of the problems. It has revolutionized the healthcare system, and it is constantly a growing field. If we look at this diagram, which I had taken from a textbook, we can see its potential use for various diseases, but unfortunately the reproductive medicine part was missing. Where can regenerative medicine help in infertility? When the ovaries are down with eggs, the men can produce sperm every 2 months till they are 80, 90, whatever. But females are born with a set number of eggs, and these eggs get exhausted by the time she is 40, 45, nearing menopause and in menopause. Reversal of menopausal symptoms, when there are problems in implantation, and also we can derive oocytes from stem cell, and when there is a thin endometrium. For the men, there is induction of spermatogenesis in oosospermia, testicular regeneration, improving the quality of the sperm, and definitely treatment of erectile dysfunction, and we also use it for embryo culture. Currently both platelet-rich plasma and stem cells are being used. If we look at the ovary, in the cortex, that is the outer part of the ovary, you can see that there are certain dormant cells which can be activated to become active oocytes, and this presumable site has helped us to use the ovarian stem cell location and help the stem cells home in there and produce new eggs. There are many studies where they have formed oocyte from activated germ cells. One of the study, first one was, which gave us the idea that oocyte formation by mitotically active germ cells purified from ovaries of reproductive age women. And here there was another study where they showed that there are new agents in infertility treatment where they had in fact used allogenic stem cell transplant, and they could recover the function in 14 to 24% of the patients. But now we are doing autologous transplant, so the results are much higher and no need for immunosuppressive therapy. This was the ROSE study designed to find out that how bone marrow derived stem cells can recover the ovarian function. They were laparoscopically injecting this in the right ovary, and the end result of this study was quite favorable with resumption of menses, improving in the hormones, and even achievement of a pregnancy. This was another study which was published in ASHRAE, and they said that European Society of Human Reproduction and Embryology, where they found that the PRP, when it is injected in menopausal women, it can restart their menstrual cycle. And there was another study where they activated the folliculogenesis with platelet-rich plasma, and this was mainly indicated for perimenopausal women, women with low egg reserve, low anti-Mullerian hormone, less than 35 years of the age, and even over 35 years of age, and mainly for women with premature ovarian insufficiency. More and more females in this era are seeing their eggs getting exhausted fast. And we as Indians and South Asians have a lower ovarian reserve compared to our Western counterpart. We are 5 years biologically ahead. So Indian women should start worrying by the age of 32 about their egg reserve. One more study where they did the stem cell autotransplantation and 2 live births were reported, and they had injected this stem cell derived by apheresis into one uteroarterial artery by catheterization. So now these 3 main groups we targeted at our center, and the inclusion criteria was with a normal karyotype and patients mainly between 80 to 40, but we have done up to 45, and 47 and 48 for menopausal reversal. Patients with exclusion criteria was when there was an autoimmune disease, any sign of malignancy, abnormal karyotype, and patients with secondary ovarian failure, that is the hypothalamic cause. How did these stem cells act? These stem cells derived had action on the ovarian sex hormone. It reduced the apoptosis of the germ cells and increased the number of follicles. But most likely it acted on the granulosa cells easily. The methods were PRP or stem cells from the bone marrow, and the instillation method was either laparoscopically under direct vision or ultrasound guided. We have done total 102 cases, where 2 were doctors for menopausal reversal getting a good effect for 12 months, and the remaining 100 patients were purely for infertility. There were 11 which were injected laparoscopically and 91 which were injected transvaginal guided, and we had mixed mainly PRP and less of bone marrow derived because the females were resistant to get the bone marrow. Out of these 91, we have a positive in 24, 47 are in process, 10 we could not get a good result and had to cancel the cycle, in 13 there were negative results, and 1 is only lost to follow-up. Their low AMH was 0.66 and minimum being 0.01 and maximum being 1.2 with a mean age of 36 years. The ultrasound guided process is here. I'll just show the process. The video if it works. What we do is these ovaries are very small. Transvaginally, as soon as the bone marrow derived stem cell concentrate is ready, or as soon as the platelet rich plasma is ready, we activate, and this was what Shankar Narayan had emphasized, that as soon as you activate, the potency starts getting lost, so you should keep everything ready, the anesthetist ready, the OT ready, and then get it activated, and within 15 minutes start injecting. This way, the video is a little long, so I'll jump, but transvaginally we inject it and we reach the ovary and do it. If the ovaries are very small, we would insist on laparoscopy, because in laparoscopy we have I will just show if I can run it a little fast. This is the ovary, you will see here. This ovary you can see, and then in the cortex we try to inject under ultrasound guidance, that 2 ml on each side. If it's very small, could be less, but not more than 2 ml. We have to be careful about the ovarian abscess also. And we can literally see the color flow getting better and better. This is the laparoscopic procedure. Whenever a female is undergoing laparoscopy for some other reason, we would want to do it because this is under direct vision. You can go to the hilum of the ovary where the blood vessels are going, and you can inject it over see the size of the ovary, it is so small, but ultrasound guided we can definitely inject it, but the laparoscopic guided is definitely a better procedure compared to the ultrasound. This, how to start? So my first couple was an homeopathic doctors in the region. They had AMH of the wife had 0.3, and they came to me and I counseled them that this is one new, she was just 27, so I thought she is the ideal case. She refused for bone marrow, so we went for the blood platelet rich plasma. We injected. 3 months later we did her IUI and she got pregnant, and again while the baby was growing, 9 months old, she got spontaneously pregnant for the second time. This couple was from US. The husband has Parkinsonism with very few sperms which we had to aspirate from the testes, and wife had a low AMH. First 2 cycles we did without ovarian rejuvenation. There was arrest of the embryo, and the embryo that grew was very bad, so we suggested. And then in January 2018 we did this, followed by medical therapy. She came back in June, July. We did 2 cycles. We had lovely embryos. We transferred 1, and this is the outcome, this beautiful daughter that they have. This patient is very interesting from UK. She had 2 cycles in UK. Both the time only 2 eggs retrieved, and both of them got arrested. And the doctors in the UK said that you think of donor egg and go to India. The husband heard about me doing this, so he called up. He said, we'll come for ovarian rejuvenation. Laparoscopically we did the rejuvenation in December, and then I called him in March for the IVF cycle. So 6th March was her expected date. She arrived on 4th to start the cycle. She never got her periods. We found out that she had a spontaneous natural pregnancy, and she delivered a healthy baby girl. So these are the interesting cases. This one was very interesting. This is a young girl who was working in a radiotherapy department, and she never used the pelvic shield, and because of the radiotherapy, her menstruation totally stopped. Her AMH had gone undetectable. I just suggested that why don't we try an ovarian rejuvenation in her. She did not agree for bone marrow, which would have been ideal. We did the blood platelet rich plasma in May. From July she started having normal menstrual cycle, but last month, 2 months back, she messaged that now it has stopped again, and I have called her for a bone marrow derived stem cell. But you see, in a radiotherapy damaged ovary also we could get the menstruation. And this is one paper where the world's first baby with ovarian autologous at the age of 45 was also mentioned. Embryo culture. This is interesting bovine study which we have just tried, but no such data we have collected. We are now trying to develop this, that whenever this platelet concentrate is used to grow the embryo, the quality of the embryo is better, and they used to inject it in the horn of the cow also at the same time, and they found that the intrauterine administration also improved the implantation and the embryo also grew better. So the outcome shows that with the platelet concentration and 5% fetal calf sample, the increase in the blastocyst was really great, and the percentage of females getting pregnant were also higher. Stem cell derived oocytes is the future, and it has already been seen in the mice. Now the role of regenerative medicine in treatment of male infertility. Azoospermia. Our study is small, but it is very encouraging. This was one study when they found out that in the hamsters, they used to give busulfan to knock off both the testes, and there was azoospermia. And then after 21 days interval, they injected the bone marrow derived mesenchymal stem cells in one testis and not in the other. And after 35 days, they removed the testes, and they found that where this bone marrow derived concentrate was injected, that testis showed seminiferous tubules, and sperm started developing. The other was platelet rich plasma in the mice testes directly beneath the scrotal skin, and there also they found that the activity of the growth factor helped to develop the sperms. This is one clinical trial going on in the Middle East where they are injecting intratesticular transplantation of purified autologous clusters of differentiation CD34, 133 and mesenchymal cells for treatment of non-obstructive azoospermia in male infertility, and the outcomes are very encouraging. They found improvement in testicular morphology, sexual function, semen quality, producing primary and secondary spermatocytes, spermatids, and even mature spermatozoa. So this is very encouraging. One more study that they found in the Japanese group, and they have differentiated the embryonic stem cell from mouse to functional spermatozoa. At our first case we took was a patient with a donor egg because the husband's sperms were really bad, and the wife's age had already crossed the good oocyte reserve. So when we did, they bent upon using their sperms only. So first time we could not reach to blastocyst, second time, and it is said that the paternal DNA reflects on the embryo from day 3 to day 5. So we suggested to him, we did this, waited for 3 months because spermatogenesis is almost a 70-day procedure, and then we did it, and we could get lovely blastocyst, and a healthy baby was born. Another patient was from Surat. He had 6 failed cycles. We tried the first. Tobacco chewing is the worst culprit for deteriorating the sperm parameters. So this patient came first to an IVF with us. The wife gave beautiful eggs, but by day 2, all of them stopped growing. So we suggested this. His DNA fragmentation was 61%, which is really, really bad for the spermatozoa. And he agreed for this. And then after 3 months, we decided to do the IVF cycle. We got 8 embryos that reached day 3, and we transferred 3, and a healthy baby was born. So total of 7 cases, 3 already we have positive. 1 we forgot to do the Y microdeletion test. If that is here, like there are exclusion criteria in ovarian rejuvenation, even in sperms testicular rejuvenation, we should not do it for men who have Y microdeletion and for men who have AZC. If the C segment of this is missing, azoospermia factor, then on the long arm of the Y, then also we should not do it. And 2 are, we are still trying, and 1 has lost to follow up. Thin endometrium and repeated implantation failure. There are many reasons for this, from chronic endometritis, tuberculosis, fibroids to various surgeries, DNC, which can cause Asherman's and thin endometrium. And the treatment modalities are number of them, but nobody had thought of regenerative medicine in this. So we started to do this with bone marrow derived as well as platelet rich plasma. This was a study where they've shown that platelet-rich plasma, when it is put into the endometrium, it improves the outcome. It was a small study, but it had shown a good improvement from all these patients. There is another study where they had used platelet-rich plasma in repeated implantation failure. That was thin endometrium. This is repeated implantation failure, and the conclusion was that it is effective in improving the pregnancy outcome. And normally what we do is we inject this platelet-rich plasma 2 to 8 days before either the intrauterine insemination or the embryo transfer, which is very simple, but that will be effective for that cycle only. This was a female where we used a bone marrow derived as well as the powder which we got from Trichy, and she had thin lining. 3 to 4 times her embryo transfer was cancelled. Finally, with 2 hysteroscopy and this implantation, we could get a good lining, and she delivered a healthy baby boy. How do we do it in the hysteroscopically? This is the procedure. You inject you go inside with the hysteroscope, and then once you can identify the endometrium, where you see white area, very patchy, it is not there, you just go few millimeter, very few millimeter beneath the endometrium that you are seeing, and you go and inject like this with the needle, the platelet-rich plasma or the bone marrow-derived stem cells. And this can work for few months because it is done previous cycle, then you see the endometrial growth, you see the blood flow, and then you do the transfer. But this effect is longer than just putting it inside the uterine cavity. And this study, which was path-breaking, published in 2015, where in Europe, the iGenomics received orphan drug designation for this product of stem cells, and which was injected directly into the uterine artery spiral arterioles. Carlos Simon had 16 patients where they could not take it from the bone marrow, but GCSF was given. The stem cells were migrated to the peripheral circulation, and by apheresis, taking 2-3 times, they separated it and injected into the uterine artery spiral arterioles, and their cases were really successful, and they could see this, that the endometrium had improved on hysteroscopy, the color flow had increased, and they had good results. So we thought of doing it, but apheresis was expensive. We did not want to use GCSF repeatedly. With help of Dr. Ravi, who came to my center January 16th last year, we collected 3 cases for this, and one was Asherman's, one was refractory endometrium because of tuberculosis, and one was patchy. And what we did is we derived the bone marrow, we prepared the autologous cells, this is the methodology, and then these samples were tested for all the infections by the real-time PCR method. And this is our setup where we collected the bone marrow, the stem cell lab where we manually prepared the stem cells, bone marrow derived concentrate, and this is our cath lab. And in the cath lab, we injected this from both the femoral arteries to the opposite side internal iliac and going into the uterine artery spiral arterioles. I hope I have the video. I'll just show you. It's interesting procedure. And by the microangio catheters, they reached directly into the uterine artery spiral arterioles, and 2 ml, oh, it's not so good, was injected on both the sides. And in one patient, we found that one hypogastric artery was totally blocked, not seen only. And later on, we waited for 3 months, and this second patient, Manisha Waghela, she had very thin lining, very bad tuberculosis, and in Ahmedabad as well as Mumbai, they were told that go for surrogacy, there is no future for you. She was young, the family was very cooperative, and she had 3 failed IVF cycles in spite of this thin endometrium. So we did hysteroscopy, we cut the bends, we hysteroscopically also injected, and mainly we did this procedure. After that, her lining could go up to 5, 6 and 7, and then once we give progesterone, it again came down at 5, and at 5.4, we transferred the embryo in May, and in February this year, she delivered a healthy baby boy, and which is the first case in India because nobody has done, and after Carlos Simon also, this is the first case in the world which a very simpler technology, more than what he had done, a very simple, but we have done 2 more cases, and the 6th is on the pipeline, but we are going to get it published in one of the good journals. So this was the achievement of the bone marrow derived stem cells. Now treating, we know the guidelines that we cannot treat the stem cells, culture or passage the stem cells without the permission, but yes, we can do this autologous derived stem cell concentrate and inject it immediately into the patient, and we are not doing anything illegal in that. To summarize, I will say that various techniques are available, but stem cells are now being considered as potentially new therapeutic agents for treatment of infertility, for endometrial regeneration, ovarian rejuvenation, oocyte production, and activating the process of spermatogenesis in men. This orphan drug designation which the European Society has given is a very big achievement. Erectile dysfunction, many doctors are using it, and definitely more research is needed. But we can use it for all these indications in a patient or a couple of infertility, where they can get better results after doing this, because cycle after cycle you don't get good eggs, you don't get good sperms. Ask them to wait and at least give them this opportunity before they leave you, or before, because there are many who don't want to use their donor eggs and donor sperms. That is the first thing they say, that either it's our child or we don't want it at all. Regardless, a number of generic problems must be overcome for the development of successful clinical application. Risk of tumor formation is very low when you are using this. The viability and the function of the engulfed cell should be documented. We have to overcome the immune rejection and facilitate vascularization of the regenerative tissue. Various indications has given optimism, but we cannot overstate the promises of the technology in its current form. This is a promising vision, but how the research could change the world of fertility and aging is one of the important criteria. But that does not mean that the infertility clinic should start giving open invitation to the desperate infertile couples from various centers claiming that we have success with stem cell therapy and male and female infertility. That is absolutely wrong. We need lot of trials, and that will definitely improve the efficacy of the treatment. And thank you once again.
I just want to know how much of blood you aspirate, how much you inject.
Bone marrow we aim at 80 to 100. 80, yes. 100. But many a times we get up to 60, 70 also less. But 80 is our aim to get from the bone marrow. And from the for the blood for platelet plasma, it's 20 ml. Okay. And injecting is about ovaries, we can go up to 2 ml on each side. If they are very streak and small, maybe little less. Testes, it is 0.5, 0.75. The moment it starts getting turgid, we have to be careful, because if it becomes very, very stony hard, then chances of necrosis increase. Intrauterine instillation is again 0.75, 0.5 depending. And hysteroscopically, we can go up to 2 ml again.
Now about the testicle, madam, you said 0.7.
0.5 to 0.75.
0.5 to 0.7.
Depending on the size and the volume.
In your presentation, you also has mentioned that you can inject subcutaneous.
Yes, we do subcutaneous at 4 points. We go direct intratesticular.
For the same patient?
Same patient on one testis, within that 0.5 to 0.75, we inject subcutaneous and directly intratesticular. We tried near the reti testis, calling a urologist, but rather than that, this methodology has worked better. Subcutaneous and intratesticular at 4 points.
Why subcutaneous?
There is one study which I showed in the mice where they have seen that after injecting subcutaneously there was a result. So we are using both when we are injecting that 0.5 to 0.75 subcutaneous as well as this, both we do.
Basing on the concept you have gone on.
Yes, on that mice concept only I have gone.
Dr. Zahir Hussain is an orthopedic surgeon implanted at Tosh Hospitals in Chennai. He is assigned as a specialist in joint replacement surgeries. As an expert in joint replacement, he deals with knee replacement, hip replacement, and shoulder replacements. After completion of his initial graduation, Dr. Hussain completed his MS in Ortho and MCH in Ortho from the United Kingdom. He underwent intense training abroad and worked as a trauma surgeon and orthopedician for a span of 4 years. Dr. Hussain is also a member of various organizations like Indian Orthopedic Association Tamil Nadu, Orthopedic Association and Madras Orthopedic Association. He is a specialist in joint preservation and joint replacement. He is a pioneer and specialist in stem cell knee cartilage regeneration, instrumental in introducing single stage knee cartilage regeneration in India. Over to Dr. Zahir Hussain for his lecture.
A very good morning to all. I thank Dr. Ravi and Dr. Shankar Narayan's family for inviting me for this event. I knew Dr. Shankar Narayan from 2014. Actually, I started my stem cell work in 2012. So I'm far more very junior to Dr. Shankar Narayan, even though he has reached me and he walked into my hospital and introduced himself, and then he was asking about my work on stem cells, and he appreciated. And every time when he visited Chennai, he visited our hospital. And actually, I first met Dr. Shankar Narayan. Then only I met Dr. Ravi, and they were always encouraging me. Those time in 2012 when I was talking about stem cells among the orthopedic community, it was like Greek and Latin for them, and everyone was criticizing and talking negative about it. In those times, Dr. Ravi and Dr. Shankar Narayan used to come and encourage me about the work on stem cells. And every time, even every 3 to 4 months, we used to have a conversation about the work, what we are doing. So, such a nice person, without even knowing each other, he just walked in and encouraged me to do the work. And unfortunately, actually, both Ravi and Shankar used to call me for lecture. I always tell that whenever I find time, I'll definitely drop in Trichy to meet him in his lab and do some lecture for the trainees. Unfortunately, I've come to give a lecture on his memorial day. Anyway, I think we all should respect his dream, and we should take his legacy forward. Dr. Ravi has given me a topic on cartilage regeneration versus joint replacement, which is a very difficult and a controversial topic because cartilage regeneration is an emerging technique, and joint replacement is a well-established gold standard treatment. Coming to orthopedics, it's like a carpentry, and orthobiologics is like gardening. So it's entirely total different sort of job. And I'll be talking about more of my clinical work rather than basic science, because here I see a lot of different type of crowd, students, general public, clinicians and researchers. So I'll just give an overview about orthobiologics rather than giving more of technical details. Dr. Shetty and Dr. Kim are my mentors. Dr. Shetty is from Kent, and he is a professor there, and I have worked under him directly, and he is one of the Hunterian professors of Royal College of Surgeons, and he is one of the pioneers in the world in cartilage regeneration. And Dr. Kim is also one of the senior most professor from South Korea, and he is doing a lot of work on research on stem cells and cartilage regeneration as well as orthobiologics. Both of them, without them, they have taught me everything about cartilage regeneration and stem cells. So first I would like to talk about osteoarthritis. What is osteoarthritis? And you can see this side of this picture where you can see a white, smooth, soft structure that is called cartilage. In Tamil we call it as kuruthelumbu because it is 3 mm at the end of the bone, each bone, wherever the joint comes. That is a smooth surface. It doesn't have a blood supply or nerve supply. So the other side of the picture you can see there are some cracks. Okay, this crack get exposed to the bone. So bone has got a rich blood supply and nerve supply. That's why when it comes in contact we get more pain. So when it's smooth and nicely gliding, we don't feel any pain at all. So this is the X-ray picture of an osteoarthritis of the knee. Whenever you go to an orthopedic surgeon, first thing they'll do an investigation of X-ray, and you can see on either side of the joint, you can see there is a smooth gap, almost like 6 to 7 mm of gap, and that is not actually gap, that is a cartilage. Cartilage does not get exposed to the X-rays, only the bones get exposed. Suppose if you're seeing a smooth gap in between the bones, that means there is a good cartilage. The amount of cartilage is determined by the space. The other side of the X-ray, here you can see the inner side, that is the medial side, where we call it as a medial side in the medical term. Here there is no gap at all, the bone is rubbing on the bone. That means the cartilage is completely worn out. Here the outer side of the joint, there is a good cartilage available, and also some bone spurs are, you can find some bone extra growth. And this is mainly 95% of the osteoarthritis patient or medial joint space is involved, that is inner side of the joint is involved, because the whole body weight goes through the inner side of the joint. So that's why most of the patients, 95% of the patients will get the curved legs when it is damaged, and if they leave it without attention and treatment, it will go for varus deformity and the legs gets curved. So what are the causes? As I said, athletic people will get more often, more early in the 45s or 50 age group. Normally general population might get osteoarthritis at the age of 60. They might get a little bit earlier because of the repetitive use of the knee. And also aging. As our hairs gets gray, this also wear and tear occurs, and your cartilage gets worn out. And some cases hereditary, and now very commonly we see patients in younger patients, that is mainly because of obesity, due to the overweight, because the cartilage has got a strength to carry only certain amount of weight. If you add on the weight, so automatically the wearing of this cartilage will occur sooner. And repetitive stress injuries and other illnesses also involved, like rheumatoid arthritis and other autoimmune disease also might cause arthritis. So what are the symptoms? We see pain, swelling, stiffness, and these are the common symptoms of the arthritis. What are the treatments available? First, when you go to the orthopedic surgeon, they'll give initially, when patient complains of knee pain, they give the painkillers, then they go for ointment, and then physiotherapy is prescribed. If the physiotherapy doesn't work, then they'll prescribe some injections like steroid injections or hyaluronic acid injections. And again, if the patient doesn't want to go for surgery, they might give some braces. These are the treatment available, basic conservative treatment. Next is, now you would have heard a lot of PRP injections, that is protein rich plasma. In the stage 1 and stage 2, that is if there is no deformity, only less than 50% of the cartilage is involved, and the symptoms are less than 2 years, then we can try this PRP injections, where we can give intra-articular injections. Maximum of 2 injections is more than enough, and this might slow down the progression of the disease. That is the main action. It has got an anti-inflammatory effect, an immunomodulatory effect, which might last for maybe a year or so, or maybe 2 years. And particularly nowadays we are seeing PRP injections are being used in more advanced cases like with the varus deformity. That is because of the lack of knowledge of the physician. So it may not work completely. The PRP is not the solution for everything. Only in early cases we should use this. Next is a gold standard treatment, knee replacement. This treatment was introduced in 1970s. Now today this is the treatment for gold standard treatment for osteoarthritis, followed all over the world. It is such a wonderful operation. If it is done properly, it will last for more than 20 to 25 years. Of course, there are some complications. Around 80% success rate is there. Another 20% we see some complications like infection. If we get an infection in a knee replacement, it will be a disaster. And there are partial treatment, partial replacement is also available. And this is a major surgery. At least patients need to stay for 50 to 60 years, and 5 to 6 days in the hospital. And since it's a major surgery, people who are a little bit older, like more than 65 to 70 years, they are more reluctant to go ahead with the major surgery. That's why patients delay the process of getting into a knee replacement. What is knee replacement? Since I've been given a talk on knee replacement versus stem cell, I would like to show what is treatment of. So this is the surgery what we are showing on knee replacement. Here you can see the white surface, smooth surface, that is a cartilage. In knee replacement, here we are seeing the complete loss of cartilage. So yeah, we cut the affected portion of this cartilage. Almost 8 to 9 mm of bone pieces are cut on either side of the bone. And the knee is balanced. And we use the metal implants to replace the surface, and in between the metal implant we use a polyethylene insert. So now we get a smooth knee, and also pedal also is replaced. This is a standard gold standard treatment followed all over the world. So coming back to cartilage repair strategy, we have seen the replacement now. So what are the available options for cartilage repair? So initially when we 20 years back, when they thought of regenerative surgeons, they went in through arthroscopy. They completely debrided and made some microfractures which had some cartilage formation, but it's not like an hyaline cartilage. There is no strength of that cartilage which is formed. It's almost like a fibrocartilage. So that failed, and then some soft tissue grafts were introduced, and then some osteochondral transfer, that is normal area where we had a good cartilage, we removed such cartilage and transferred to the affected portion. And then came scaffolds, lot of scaffolds being used, and then autologous chondrocyte implantation, AC, we call it ACI. Then came the mesenchymal cells. Autologous ACI has got a two-stage procedure. That is, once you have to take the cartilage cells from the normal area without affecting the normal cartilage, and send it to the lab, and it was cultured, and again it was re-implanted. So it was a two-stage procedure. So the cost was little bit higher, and even the results are not that much encouraging. So then we moved on to stem cell therapy. That is, we are using autologous bone marrow, and which was sent it to lab, and again the expansion, culture expansion was done. So again, it was a two-stage procedure. So to minimize the cost and to avoid the two surgeries, we went into next stage of a single stage cartilage regeneration procedure. So I'll just skip because already the previous speaker has talked about this about the functions of stem cells. So what are the advantages of mesenchymal stem cells? So it's easy to procure. Just we take a needle and take a bone marrow from the iliac crest, and so it's there is a very much relative ease, and there is not much of a big learning curve, and it is non-immunogenic and non-tumorigenic. It is not affected by intrinsic tendency of the cells to lose their phenotype during expansion like ACI, where we do a culture. So you do not need to do a cartilage biopsy, because you have to do a cartilage biopsy in the normal area, so there is a donor site morbidity, and also we can avoid the two-stage procedure, and the cost also will come down. So in single stage procedure, what we are using a BMAC, that is bone marrow concentrate, as well as to hold that bone marrow concentrate in place, we use a scaffold. We use hyaluronic acid and low molecular hyaluronic acid and fibrin gel, which consists of thrombin fibrin mixture, which holds this bone marrow in that place, bone marrow concentrate in the place. So it allows a better fixation, and it is like same like injectable. It's an addition, just a gel addition, that's it. So what is the aim of BMAC treatment in OA? It is to relieve the symptoms of the patient and improve the function, to restore smooth articular cartilage surface, to preserve the patient's own knee rather than having a metal implants, and to delay the joint replacement in fit and active individuals. So again, this is, I'll try whether it's playing, we'll see. Yeah, I think it's playing. So you can see the whole procedure. It's a keyhole procedure, is done through arthroscopy with a small incision. So you can see the affected portion. As I said, medial side is very common. The cartilage is more worn out. So we just go and debride the surface. This is a real time you're seeing. And this 3D animation to make you more understandable. So we go till the underlying subchondral bone. The subchondral bone is a powerhouse of the knee, and that consists of the precursor cells. So as I said, the cartilage doesn't have a repairing capacity. We have to stimulate the cells, so we do a microfracture, and also this microfracture brings the bone marrow from the available bone to the surface and also stimulates the cells there. And also when we inject from outside, it holds it. So from the iliac crest, we aspirate around 40 ml of bone marrow. We have a special kit for that. So this kit has got a 3 compartment, and we inject the whole 40 ml, and we use a double centrifuge method. First centrifuge, it concentrates the cells and brings down, and the buffy coat appears, and then we raise the buffy coat and lock that compartment and do the second centrifuge. And then now the concentrated bone marrow has been separated, which consists of growth factors as well as mesenchymal stem cells and cytokines. We then inject along with the scaffold which I mentioned earlier. So we just implant in that area where the bone is affected, and it goes and stays in that, since we are using the scaffold. So it sets within 2 minutes and it stays there. And on table, we are just gliding the knee joint, moving up and down, flexing and extending, and it takes a very nice shape. You can see that. So, patient, how do you select? Inflammatory, we exclude inflammatory arthritis, any joint inflammation, and any ligament laxity. So I can show you some results of our own patients. This is a 60-year-old lady. You can see her joint space is completely obliterated. After 5 months, you can see there is a nice gap forming. This is a 1-year result. Can you see? It's almost like equal to the lateral side. It's complete formation, and it's 2-year results, and this is 3-year result. This is the same lady. She had a left knee with the lateral compartment affected. So the same procedure has been done, and you can see the results for 2 years, 3 months. And the same patient's MRI. To quantify the amount of cartilage, we have done MRI studies, and it shows a very good formation of MRI with cartilage mapping we do. So it shows a very good results. And this is another lady here. She's also a 60-year-old lady. Can you see that? The medial joint space is reduced, and immediate post-op, and after 1 year. So this is another 50-year-old lady, bilateral again. Why I'm showing most of the case, I'll be showing bilateral, because first leg we do the patient, first knee, and 6 months we repeat the other knee. Most of the patients, they are more happy, and then that's why they're coming for the other knee. Without any compulsion, they come on their own for the other knee. So this is an interesting case. I think this is the first patient we did. This is done in 2002. This is the first case. He's at, when I came from UK, we thought of starting a stem cell work, and we are searching for patients. When we try to explain to the patient, nobody was willing to take up, and nobody believed us initially. So this is the first patient. He's ophthalmologist from Amen, and he had a injection paralysis of the right gluteal region in his younger age. When he was an infant, the injection was given. So he has a weakness of the right leg, so he used to put more weight on the left knee. So he had developed osteoarthritis of at the age of 30 itself. So he used to walk only with a stick. So he came to us. When I started having a conversation with him, and I told that he was searching for something other than knee replacement, I offered him that this is a new treatment, and he readily accepted to go through the procedure. And we did the procedure. You can see complete obliteration, and this is 3 years result, and this is 7 years, 6 months. This is the longest follow-up I have, and he's doing absolutely fine. He can operate for 3 hours standing. And recently, actually, he visited my clinic just 3 months back. That time we took the X-ray, because he's been posted in Delhi because there is war is going on. He is a coordinator for war victims in Delhi, and he visited me, and he brought another couple of patients, and we did the procedure 3 months back, and I took the X-ray at that time. He was a very happy patient, and this is a result. I think Dr. Lakshminathan is my register. Next slide. And about stem cell, the people who wanted to start the work on stem cell, particularly young surgeons, orthopedic surgeons, I would say, if there is a deformity, you have to correct the deformity. The alignment should be corrected before proceeding to any orthobiologic treatment. Suppose stage 1 and up to stage 3 you can do directly without doing thing. And as I mentioned earlier, even PRP stage 2, up to stage 2 it will work, and that too it's a temporary procedure. You have to explain to the patient that it's a temporary procedure, and it will help only for a few years. And for the advanced cases, I do high tibial osteotomy. That is, we correct the alignment. Here, this lady is a breast cancer survivor. So she came to me, she's only 54, and she came to us, and she said she was being offered knee replacement, and she said she doesn't want any metal implants, and she was really frustrated after going through this radiotherapy and also chemotherapy. And when she came in, I told that her leg is totally bent, and we need to do a correction. So we did this. Can you see that? We made a cut and made osteotomy and corrected the alignment here. And this is the immediate, 3 years result totally, you can see. And now the leg is straight. Now almost like it's 4 years she's going to complete. And this is another lady, she's only 40 years. You can see how much damage she had, and after correction, this surgery is a little bit longer because the osteotomy itself will take 1.5 hours, and the arthroscopic procedure for another 1 hour, 1.5 hours. It's almost like 3 hours surgery, but the results will be excellent and it will be very long lasting, even more than 25 years or lifetime we can give this patients, because the alignment is completely corrected, the pressure is relieved, and complete regrow of the cartilage will occur because there won't be any much pressure there. So particularly in younger patients like 40 years, imagine having a knee replacement at the age of 40. She's been offered knee replacement, so now she's having her own knee and she can sit and squat and do everything. So then there are some patients who had a little bit of minor varus deformity. So for that, this type of bigger operations like 3 hours and the cost is also going high. And we were thinking what to do for a minor less than 7 or 5 degrees of varus deformity. So I was inspired by the Chinese research paper, which have done a high fibular osteotomy. That is, we just give a small cut in this bone. The fibula, it's a non-weight bearing bone. So in China, the Wang et al., the team which has performed 100 such procedures, only high fibular osteotomy for early osteoarthritis patients. So they have found there is a good result, but they have not done any cartilage regeneration, just a mechanical correction they have done. So I thought, why not we combined this procedure with our cartilage regeneration. So for the early patients, early osteoarthritic patients with the mild deformity, then we proceeded with this procedure with the excellent results. And this technique which we have published, almost like now we've done more than 150 to 200 patients, and this paper has been accepted and published, and this is the first of its kind paper in the whole world. The Japanese Society for Regenerative Medicine has accepted our paper and it has been published in this journal. So what are the advantages of joint preservation compared to joint replacement? Hospital stay is a short hospital stay, almost like a daycare. We can do this procedure, whereas in knee replacement, the patient has to stay a week or so in the hospital. It depends upon this recovery. And it's a natural way to preserve your own joint. And it's a safer alternative for knee replacement, particularly in younger patients. And to avoid artificial metal implants, we can return our own knee. There is no restriction of joint movements after the surgery. We can sit and squat and do, particularly in our Indian custom, people wanted to sit in the floor and pray to God, as well as sit in the floor and eat. And these are the, particularly in older females, they wanted, they always ask for, when they come to a consultation, can I sit on the floor? So these are all possible with this procedure. These are the main advantages. So rehabilitation after this procedure, the next day itself I start range of movement exercises. Maximum range of movement is allowed, and partial weight bearing, 50% of weight bearing is allowed till 6 weeks, and after that full weight bearing is allowed till 6 weeks. They have to use a single stick or a single crutch or a walker to use this half weight bearing, and then we can move on to full weight bearing. But it will take at least 4 to 5 months to see the satisfactory results. And mainly I would like to emphasize that when the patient comes for with a knee problem, so I don't directly offer, unless the patient is younger, I offer this treatment. If the patient is made up a mind for knee replacement, I'll go and do the knee replacement for them, because when they compare with when you ask them to get this procedure done, and when they compare with the knee replacement patient, because the recovery will be a little bit, definitely there will be a slow recovery in this type, because the cartilage cells has to grow, it has to take its own time. So at least we are thinking here in a moderate damaged knee, at least 3 to 4 months it will take. Till then patient has to accept that, and the patient mindset should be accept for the regeneration techniques. So that's the main point for the young surgeons I would like to emphasize. So what are the complications? There is not much complications there. In less than 3 to 4% of the patient might get joint effusion after the procedure. We just need to do aspiration. And infection, so far I have done a 600 joint preservation procedure. Out of it, only one patient had a infection, and we treated with lavage, and he became completely normal after that. And this paresthesia and nerve palsy particularly, which I showed, this high fibular osteotomy, in that case, in less than 2% of the patient might get palsy of the bigger toe and weakness, and so you have to be very careful in doing retraction, and you should be well versed before doing the surgery on your own. So I am a joint replacement surgeon. Now I have become a joint preservation surgeon, but still I follow treatment in gold standard treatment for certain types. These two patients, if you see the x-rays, how much it has come out. Almost the knee is dislocated. This patient's knee is almost like turned varus deformity of 25 degrees. To be honest, these patients, when they came with the great hope of having a knee preservation, orthobiologic treatment, stem cell treatment, and after seeing the patient's results of other patients, they came to me, but I convinced them that is not possible for them, and I did this procedure. Still total knee replacement in some cases. Definitely it's a gold standard treatment, no doubt about it. Next, so coming from the knee, we are also doing a hip. So there is a condition called avascular necrosis, which you have heard. It occurs particularly in younger patients, and the blood supply to the head of femur gets affected. So those patients get early arthritis, and the standard treatment is a hip replacement. And so for that, normally we do a decompression to delay the process, core decompression. So now out in the core after doing the core decompression, we also inject bone marrow concentrate into that bone and some bone graft, so that it might last longer. In some patient it works even for more than 10 years, 15 years. So I'll just show you how we do that. We go and remove this necrotic bone, the dead bone, we completely remove it. Generally in core decompression they just do a drilling, but here we do remove more necrotic bones, and after that we inject the stem cells, and we take the bone graft from that normal bone, which we have a special instrument like that, so it removes that and keeps the bone there. So this is the intraoperative pictures you're seeing. So we push the bone graft into that areas, so that along with the bone marrow concentrate. So it gives a very good result. So other areas in non-union we can use bone marrow concentrate. So there are some patients where even after the internal fixations the bones may not unite. In that case we can do this injection. This is a results of AVN. This lady is a 36-year-old lady where you can see it's almost like advanced stage 3 AVN, and she was advised hip replacement on both sides. Now it is almost 2 years. She is doing absolutely fine after this treatment. And what is the future for regeneration? So we have seen like cultured cells, we see microfracture, we've seen scaffolds, we have seen cultured cells, ACI, and then cultured chondrocytes, cultured mesenchymal cells, and single stage repair of cells. So all are cellular type. Now we are moving in towards acellular. collagen. This is collagen is ethylocollagen from the animal source. It's separated and it is available as an off-shelf. So once it's been approved by the Drug Control Authority, we can just take it from off-shelf and use directly in the operating theater. So you don't need to worry about the regulations or anything. And I've done almost 10 cases. The results are excellent because it's still in the process of DGCA. Probably within a year's time, we are going to get this product, and it's going to be a game changer in cartilage regeneration. And for your information, that product was designed by Professor Kim and Professor Shetty, and it's been used widely in Korea now. They've already published a paper, and soon we'll be getting in India. So to conclude, although longer follow-up and RCTs are needed for this bone marrow concentrate, stem cell treatment represents advanced cartilage regeneration with a high clinical outcome scores, and it's very effective alternate to delay TKR in younger patients and very active individuals. And it's a reliable joint preservation option in ONE patients, and future stands for regenerative therapy. Thank you.
Thank you, sir. Thank you for the wonderful talk. And I request Dr. Manimaran, sir, to give away the mementos.
Any questions you can talk, you can ask before this tea break.
So that I can give the mic to you if you have any questions. I take immense pleasure to introduce him. He's MS in General Surgery from Marathwada University, Diploma in Urology at the University of Vienna, Austria. He started his brainchild STEM Orex Bioscience Solutions in the year 2011. In-depth research in the field of regenerative medicine and cell-based therapy, which he believes is the solution to address the limitations of conventional therapeutic modalities. Dr. Mahajan is a life member and Joint Secretary of the Stem Cell Society of India, Vice President of Anti-Aging Foundation Delhi, Scientific National Advisor Indian Stem Cell Study Group. He has been appointed as Honorable Associate Professor of Regenerative Medicine and Cell-Based Therapy at Dr. R.N. Copper Hospital, Mumbai. Faculty for MD Transfusion Medicine at KM Hospital, Mumbai. Dr. Mahajan's academic collaborations include those with the Maharashtra University of Health Sciences and ITM University. Over to Dr. Pradeep Mahajan, sir.
At the onset of the talk, for me today being here is a great honor. This conference carries a lot of prestigious meaning for me. In fact, the basic clinician who was becoming a researcher, which is always I ask all the clinicians, find a researcher in you, and you will find you will become a better clinician, and Shankar Narayan was one of them. Being a good clinician was becoming a good researcher. We used to have a lot of brainstorm discussions whenever we used to meet in conference. Unexpected, accidental things do happen. But this happening of accidental thing has brought a big loss to the community, to the friends, to the family, and to the nation. My talk of today, drugs, stem cells and drugs, I tribute to him as my respect for him. This wonderful panel today, which we have been hearing, is a panel which are extremely distinguished speakers. Not only speakers, they are very best in their subject, and all of them have, first of all, you should understand the clinicians who spoke here, all of them were the mainstream clinicians, and all of them have changed towards regenerative medicine. So this is one of the footprints which we should understand the way we are going to look regenerative medicine in future. Special thanks for the organizers, Ravi, Maruti Group, and the Medical College. An opportunity to be me here. What is more important for me, why are stem cells becoming so important in clinical practice? have we initially thought of why are they becoming so important in your clinical practice? During the course of my talk, I'm going to add certain specific slides to understand. You all are clinicians, you find somewhere in your practice, somewhere you're held up. In a group of patients, you cannot do anything. And you keep on trying without any success. Not your success is important, but the morbidity of the patient keeps on increasing. When we know if a little change in your thinking process from a non-living molecule, can we go towards a living molecule, which is a day-to-day natural wear and tear process which is being maintained in our body. So just small thought process will give you a bigger platform to enjoy the concept of regeneration. My today's talk I'm going to put into two parameters. One parameter will be most important for you to understand on the concept of drugs and stem cells. Having known that parameter is not sufficient for us, what is more important for us to know is this science going to be applied on clinical sites so easily? Means, when you talk of mainstream science or a science of standard of care, it is not an individual science. It's a science which is going to take to masses. It is science which is going to take a masses. Have you thought of, we all are talking of stem cells, drugs derived from it. Have you thought of, is it possible, can it go to masses? Because these are customized, personalized treatment. There's a limitation. When you talk of masses, it has to go in a volume, cross the countries, cross the ethnicity, because you can't limit to any one community, any one ratio, one place. When you talk of a mass treatment, and when I'm going to talk to you as a drug, stem cells as a drug, we need to focus. What is this stem cell in a drug? And how do we take in the second part, I'll explain you the way we can take as a mass production, as a manufacturing capacities globally, what's happening today, how do we take this to masses? What are the limitations and how we convert this into a beautiful possibility of an application of new aspects of regeneration. What is more important in this today's talk of mine is, as a mainstream regulatory rules and a practitioners, cells are not drugs. Remember, I'm repeating my sentence. Cells are not drugs. This is what is being practiced and followed. But remember, when you want to say cells and cell derivatives can be used as therapeutics, as drugs, to overcome the drug applications and a vast variety of applications, we need to go back to our application and understand when it is going to come as a delivery therapy, delivery of cells as a therapies, we need to figure out how do we manufacture, how do you produce, how do you have consistency, how do you maintain the potency. That's what the crook of my today's talk. These measures play a major role when we talk of stem cell therapy as drugs. Otherwise, individual cases, it's okay, you can alleviate the pain of one person, but what about when you talk of as a clinician, you have to reach to the mass of the people. How do we convert them? That's very important. How do we have access to these technologies? How do you have access to these technologies? This is very important, reason being that if there is no accessibility, any technology cannot change the life. Now today, clinical trials remain as a point of accessibility, or IEC approvals remain the point of technology. But the main purpose of this accessibility, getting into clinical trial or a kind of IEC approved treatments, is not to cure the disease instantly, is to get into an efficacy processes, one, and second, safety. This will give us an idea where we are heading, where we are moving ahead. This talk of today mine will give an idea how we are going to look into these two areas, stem cells as drugs. because this is a background which I wish to understand by everyone. To achieve this goal, we need to focus the existing limitation of the system. What is this umbrella of medicine? Some of these are global scenarios of market growth, but which I have not discussed today on these aspects. My hypothesis for this is that communication and information between the cells play a major role. When we talk of a therapy, there has to be communication and information. When cell to cell they talk, they pass information which is called as a genetic information or a proliferation information or inflammatory, non-inflammatory, immunomodulatory, whatever the information they pass. If this hypothesis says, if this information in a quality and quantity is maintained in the organ remains in a perfect functioning way. The moment in a quality and quantity, the information transmission is reduced, I called is an unease of the organ, and that is a disease. So when we talk of a disease in this living model, we don't require a pharmacological molecule to treat this, because pharmacological molecule only take care of signs and symptoms, but the process of disease will continue as it is. And then what we have to have external sources of pharmacology, but there is a limitation to it, as I told you. There is a transient action, the pathology will continue in the body, disease progression continues in the most of the cases, and standard examples of today, which are years together we are practicing, is insulin and nitroglycerin. How many of your insulin using in diabetic patients has cured your diabetes? None of them. Neither the nitroglycerin. 150 years we are using, but myocardium has not regenerated. It has not gone back to a normal function. So what we look, can we have something which can regenerate the tissues, regenerate the cells, and bring back not the symptoms, the entire rejuvenation of the organ. See that the functions are coming up back. Can we do that? Yes. It's a need enough for is that we need to change our paradigm of thinking in the medicine. Once we think that, it's much possible. As I told you, biology becomes the basic of this application. You can't work on the same principle of pharmacology. We need to change our thinking. Disruptive innovations and regenerative medicine comes under as umbrella, as I told you. This is a big umbrella. The function of this umbrella is not one cell. It's all type of cells. It includes all type of cells, adult cells, progenitor cells, stem cells, as well as their product components, what you can say, adult cells also, and their product components also. They are the growth factors, scaffolds, then there are new, which is coming as a new application, is from exomes and chaperones, which I'll come into. So as a drug, stem cells as a drug, first I'll put this and then take you, how do we take it to as a stem cell as a drug with regulation and manufacturing processes. The entire concept of whatever you do is a repair. Whatever you do, whichever system, stem cell is not a system of one organ. It is applied to every organ of your body. When you have been seeing some of the slides in the morning which were shown, when the labeled stem cells were given, it doesn't restrict to one organ. So it's a repair concept in your body, which is going to go continuously. Can I play a small video of this? Can you play the video? Now, these are the cells. I'll just bring in most of you know what are the types of cells. A video which will show types of cells and video which will show the types of secretomes. Because the concept, as few of our colleagues have already brought you a notice, cellular and non-cellular products. Now, the non-cellular products are those products which are derived from the cell components as a protein productions or lipid productions or hormone productions, which because cell is a microscopic factory in your body, the way the rest of the factories are, it's a system from a nucleus to the nuclear membrane to the endoplasmic reticulum, soft and rough, and then going to Golgi complex, and the protein is released in the circulation. This is a simple factory model which works in your body. If you work on this body to regulate this system, then we have all these secretomes coming in your body. The secretomes will range from growth factors, enzymes, growth factors, enzymes, then chaperones, then your hormones, all of them to put together in a basket. All those are products from the cell coming, is like pro-inflammatory and antimicrobial proteins are produced by the cells. Now, when we look in this cell production, the ratio goes to the process called as mesengenesis. Ratio goes to the mesengenesis. What is mesengenesis? The mesengenesis is a process in which the mesenchymal stem cell has a process of differentiation. Within the body, this cell remains as a drug factory for you. It doesn't have any role as a stem cell for you in the body. When you talk of stem cell in the body, mesenchymal stem cells represent as a pericytes. Depending on organ, they have different molecular presentations and different differentiation potentials. Now, these cells will act as mesengenesis when you take them out of the body, that in vitro. When they are in vitro, they are stem cells. They are multipotent stem cells. Here you can see the bone marrow. Sorry. Here you can see the bone marrow microenvironment. Here you see the environment in the lab, where we can differentiate them using different differentiating stimuli, using vitamin C, steroids, D, all those things will give different lineage. The same cell having the potential to getting into a different applications of tissues. Now, why we can use these cells as drugs? Now you get to understand the same cell, one cell can have a potential to give a lineage of every cell possibility for you, and then probably that is a source which you can apply in your therapies, in your drug testing, or dishes with the various disease pattern. That's why I am fascinated with mesenchymal stem cells. Why stem cells? Mesenchymal stem cells, adult cells. They are multifaceted, unmatched profile. They have a stem cell character outside the body, differentiating potential. As I told you, a big paracrine effect, endocrine effect. We can have an experimental models. We can have it as a raw material. We can be using the scaffolds. And most important, what I look today, when I'm talking you stem cells and drugs, is a best drug molecule, living entity. I all call them as a living drug molecule. Applications are ranging from you to talk of a condition and mesenchymal cells, either as a mesenchymal stem cell or a differentiating potential of it or a secretome of it. And the secretome, which I call is to be a drug, if you can see here, the secretome which will give an tropic effect, secretome which will give an immunomodulatory, mitogenic, then anti-apoptic, you talk of antifibrotic, you talk of an effect, it has got a secretome. And these secretomes, which till date, maybe down the line 2 years before or 3 years, we were talking as secretomes, as an cytokines, chemokines, but they all come in a group. Now we call them exomes or microvesicles. Microvesicles of the cells which are produced in the factories of the cell. Now we are going towards the train. In subsequent slide, I will show you how we can going to use that as a drugs. We as a STEMRx have been working on these kind of molecules with the reputed institutions like AIMS for exosomes, which I'll show you in subsequent one. Now, how does it work at microscopic level? You just imagine at microscopic level how it works. They are anchored around all the capillaries in the body. Take an organ, take a tissue. Any capillary in the body is anchored with pericyte. Pericyte and stem cell are the two, MSCs are the two sides of one coin. Definitely there is a slightest difference with one or two markers. Otherwise, the same pericytes, the moment injury or any kind of repair system starts in the body, they are released as an MSCs. And activated MSC, and then regenerative MSC. This regenerative MSC has a potential of regeneration plus the front side of the cell. Front of the cell plays a immunomodulatory. Entire activation of immune system takes place. The plethora of all the molecules which are released in the front side, it's a very specific cell which has got two sides. A side which faces front has got an immunomodulatory plethora which works on acting almost all immune systems so as to create a first defense system in an injury. First defense system so as to release, activate all the immune cells and prevent getting into a kind of effect of the antigens which are going to come in the body, maybe bacterium, maybe molecule, maybe anything virus. Whereas rear side, it has got a plethora of anti-apoptic, anti-scarring, angiogenic, mitotic, regenerative microenvironment, and both are brother and sisters. See the beauty of the cell. The beauty of the cell is regenerative as the entire repairing system. The entire repairing shop is available. It has got 800 plus molecules. If you count proteins, this MSC has got 800 plus proteins. It has got LL37 and antimicrobiota. Today we talk of resistant tuberculosis. MSCs are the best solution to create a solution for this resistant antibiotics. They create, depending on the way cell mutates to produce the safety, it will change its protein at the same time. If this this video runs out, it will show you these are the drug stores in your body 24/7. In your sleep also. Can you play this video? The way cells release the plethora of these cytokines, exosomes, growth factors, enzymes, you can see the way they keep on releasing depending on the environment. That is not in your control. The tissue demands and the cell releases. See, these are the cells which are releasing depending on the environment, they will release this plethora of cytokines. This is a drug store in your body 24/7 working without your knowledge. So we need to catch over this potential strength of this cell to convert as a drug store in your lab also. Because you can have the same effect in the lab to produce, depending on mutation, what kind of protein you want, what kind of mRNA you want, what kind of enzyme you want. The cell will produce for you. These are the microscopic factories in your body. At the same time, if you see here what I have mentioned, you can in the lab treat them with specific receptors and convert them into a specific action. MSC, the way we have macrophage 1 pro-inflammatory, macrophage 2 anti-inflammatory. Similarly, we have mitochondria 1 pro-inflammatory, mitochondria 2 in mitochondrial dysfunction. Similarly, MSCs also we can play pro-inflammatory and anti-inflammatory by just using this priming the receptors TLR4 and 3, which we can do it. And then again use as you want anti-inflammatory. So I look down the line 5 years or 10 years to replace if the simplest molecule like paracetamols, anti-inflammatory drugs, by the molecules which will be produced from these cells as drugs in your laboratory, and which will be in a micro quantum required, micro, not like a tablet, it will be in micro requirements, and which you can use as a drug molecule for you. And they are in the pipeline. Most of the things are in the pipeline. I am looking it in the future as a very short scope. The second which I look as a drug from the cell is microvesicles, different types of vesicles in the body. These microvesicles, apoptic bodies, exosomes, they play a major role of the cytokines, chemokines, enzymes, hormones, whatever you talk of a protein, they come under this category depending on their size and duration and the type of cell. Now, anti-apoptic bodies or apoptic cells which are going, they produce apoptic bodies. They by exocytosis. Exocytosis means the cell wall when it is dying produce bubbles, and they carry certain gene informations like mRNAs or DNAs in it, which normally will act as an information to the environment to change in. Give the information to other cells. If some cells they want to save, they will save some cells also. This is what the nature's phenomena. So they will play a major role of these apoptic bodies. exosomes are the smallest protein molecules which range from maybe 1 micrometer to 30-50 micrometers, and they are all proteins. We will see in short scope of all these molecules how we can convert them into drug molecules, also how we can use in therapeutic way for these molecules. Now if you see this picture, you will see how it's coming up like an exosome, which is smallest one which I showed you here. Then antipoptic, it comes at the size of a microbacteria. Then it comes and microvesicles. And depending on the indication, these cells, these cells in the body, they produce these kind of entire vesicles, which we called as extra vesicles of the body, of the cells component. Now these extra vesicles, if you see, has a very powerful effect. They are cell derived, they are non-cellular, most safe. You could see it from a eukaryotic to prokaryotic cells, not only in adult. If you can see the primitive single cellular structures, there also you will find. One of the, I was just discussing what we studied biology in 10th and 12th is a medicine today, what we are going to apply. This all we have learned in a biology book in 10th and 12th. And this is what is coming as a science today to apply as a medicine. This is a wonderful part of it. We studied in school and medical schools. We never thought what we look as a pathology and physiology will change our dynamics to into therapy. We just learned as a pathology and physiology functions. We never learned, can we convert the same physiological functioning role, molecule or a cell into a therapy. And now the paradigm changing is bringing to us to understand, yes, we can do that. These most regular specialized function, their job is intercellular signaling, waste management, and various hormone or enzyme roles they play it like. These vesicles can potentially be used as a therapy, as I told you, as even diagnostic in cancers. Exosomes play a major role in microscopic diagnostic in a very early stage when the cell is at a level of cellular changes taking place. These exosomes can play in a peripheral blood diagnostic tool, and there are so many diagnostic tools have come as a drug molecule which you can be using. Now this is how they are placed in the cell: proteins, mRNAs, miRNAs, and they are released into circulation. Now, if you see the drug delivery in cancers, particularly organ tropism, where the metastasis takes place, as I told you, could be a diagnostic, could be target based, where you can target the drugs to these things as a drug one. Naturally, they occur in the cell. That is the reason they are having minimum side effect. There is no, I would say low side, though I have written, there are no side effects of it. Like even if you want to have a side effect, it will not have, because they are very selective. Very selective means on the environment, they will work. Even if you want them to do some complication, they cannot do complication, because the microenvironment of the body is so designed, so perfect, they cannot take up any other role than they are made for. This is a very important concept. This science is a very safest way. I would say the beauty of the science is that we all write so many medicines. How many of us know there are so many medicines we prescribe, they have interaction each other. In the lab is different, in the body environment is different. But remember, these molecules, they don't have anything like that. They are the safest way to use in the therapies. And we can deliver to the specific organs, these of them. These microvesicles, again, little bit larger size, surrounded by phospholipid, maybe 100 to 1000 nanometer size, of a bacterium size, which I explained you. Again, they repeat as an exostosis of the cell membrane, that is a plasma membrane. Then they are usually produced by platelets, red cells, endothelial cells, and other adult cells, and which we can produce in the lab by using differential centrifuge. That is differential centrifuge we can produce in the lab and monitor with flow cytometry and capture based assays. Apoptic bodies, as I said you, they are also of the size of 1 to 5 micrometers mid-size, like a platelet size, which are of the platelet size, but they usually come from apoptic cell, as I told you earlier one, and they also carry oncogenes or gene material informations which can be helpful and usually useful in immunosuppression. Exosomes. There is a new dimension which right now is a very hot topic in the regenerative medicine, exosomes. And in my opinion, if you ask me, in future, cells will be replaced by exosomes for every treatment. The way as I said you, there are microscopic factories in the body. The same factory of cell can be made in your in vitro in your laboratories, where the cells can be giving you a range of membrane vesicles which carry all these signals to different organs in the body and target them. We can give target-based treatments with them. This is the future of medicine, which I look cells and drugs, which if I would have not spoken this today, probably the vision what we have in the future, we would have not understood. Now, though it was researched quite early, the same like all the exosomes or extravesicles are phospholipid layers. As I told you, exocytosis, they come out. And they also predominantly, the beauty I'll tell you now, these exosomes, if you take from T-Rex cells or immunity cells, you have an entire immunomodulatory sequence of drugs. The way I told you, MSCs can be done. Similarly, they can be done. And depending on the type of cells, you can produce the drug molecule, which is used for a regeneration, which can use an immunomodulation, you can for an anti-inflammatory effect. Everything can be done from this. Biological functions on the cells include the direct contact between the surface. How do they affect? Use it. They can either fuse with the cell wall into cytoplasm, or they can go inside the cell, that is endocytosis, or they can act on the cell membrane itself. There are three ways. The questions which I was talking to doctor today in the morning about why exosomes could be a mechanism of transdifraction or fusion of the cells this is the only mechanism by which the cells can be at a molecular level. We still don't understand how the cell gets into differentiated or doesn't differentiate. What is that happens? These are the exosomes which play a role at that level to change the transdifferentiations or surface action. The different biological functions, both in normal and pathological conditions, we can have. Unnecessary proteins and molecules can be eliminated from the cells and blood coagulation. Intracellular and intercellular communication also have an inhibitory and regulatory effect. Now, in case of inhibitory regulatory effect, I'll show you some of 1 or 2 slides, how they work in the immune system. Here also you can see the exosomes which are produced by the cell. They are trying to give an effect in activation of NK cells to go an immunomodulatory property. Similarly, DC cells they will play. The DC cells, whatever the immunoproperties are produced, they are doing the activation job here. The next slide will show you the activation and inhibition. All are roles functionally played by exosomes. If you see DC cells, other immunity cells, they all play like MHC complexes. If you see, they are produced by them. These are also exosomes. Then also inhibitory effects, which you can see here, which are produced by exosomes. There is a cyber war going in your body always, which you are not aware. This cyber war speaks the biological war where the immune system will win or immune system will lose through their cytokines. This is one slide which is very important for you, a different aspect of exosome to apply. Whenever we talk of any specific receptor like HER receptor in breast cancer, which is producing oncogenes or oncoproteins, and we are using antibodies, Herceptin antibodies to target the cancer cells. Now remember, whenever we are using antibodies here, these oncoproteins which are produced will block the antibodies here, proteins. And the effect or what you see resistant to these kind of molecule is because the oncoproteins which are produced by the cancer cells, they block these antibodies. So what new science is saying, you go for apheresis, remove these oncoproteins and then give your drug. Your biological potency of this molecule will be absolutely double, triple, and they don't find resistance to it. The resistance, what we talk of the drugs today, is because of these kind of proteins which are produced by the cells. So apheresis, along with these technologies, will play a major role to improve the bioavailability and functional results of these kind of molecules. People are working on cancer, DC vaxxer, everybody knows. I need not talk on this, like the way, these are also exosomes. Now, let's see the platelet as a drug molecule. We talk of 5, 6 of them, but there are many of them are there, growth hormones. Not only growth hormones, we will come to the next plate where how we can see the number of 100 plus proteins are produced by platelets, 100 plus proteins. In addition to that, if you see the molecule which is present with the cell membrane, microtubules, cytoplasm, and what is more important, your dense granules, alpha granules, not only that plays, the mitochondrial volume also plays a major role in therapeutic application, the platelets, because mitochondria carries its own genome. That's the reason sometimes if you take repeated platelet transfusion, you will find some kind of immune reactions. This is because of the mitochondrial gene. And if we can remove mitochondria and then use the cells, then they are absolutely immune free, absolutely immune free. Now, these growth factors which are present in the dense molecules and alpha granules, they will have you can see the dense granule application, huge number of molecules are there. Alpha granules, huge number of molecules are there. These can be a strong molecule for therapeutic applications. Probably the concept of Ravi which is working is around these molecules, and further if we reprocess it, we still can target with individual molecules instead of going in a complete like a basket of all drugs in one. We can still segregate some of them and target based we can work upon them. It's much possible with using apheresis technologies where we can target different proteins, take out them, we can use a chromatography to take out them and use them for the different therapies. Now here you can see there are microparticles, protease, antiprotease, adhesive proteins, cytokines, chemokines, growth hormone, mitogenic hormones, and the plasma proteins. They together, the environment doesn't work with one protein, as I have been repeatedly telling. It's a total conglomerate micro environment which plays a major healing process. Why I'm talking to this is that there are new generation clinicians are coming up. They should understand the concept of application of regenerative medicine. When they go at a molecular level, I am very confident all of these budding surgeons and physicians will become very powerful on a clinical side once they know why they are doing it. Enzymes are produced as a functions, I need not repeat again. Now these chaperones, again a kind of protein. In all of your hospitals, your diagnostic setups or your factories, you have a quality management system. Chaperones are quality management proteins of your body. They are present as an ribosome-like molecules on endoplasmic reticulum, representing correction of the bad folded proteins. When proteins are folded, a protein which is produced by an endoplasmic reticulum may be enzyme, may be a hormone, may be a kind of any kind of cytokine, chemokine, protein, anything you take it like. It has got a specific shape. It has to be produced in a specific folded protein. And during the process of this production, transcription is taking place, some of the protein molecules may not be folded properly. So chaperones are the great proteins which a job is to remove these bad proteins, destroy them putting into protease cycle or lysosomal cycle, or put into recyclation and produce a new molecule of protein. So they play a major role. Now technology have come. Can we improve the inner cellular environment by improving, like Alzheimer protein? We know what is happening there, which proteins are accumulating, we know. Chaperones will be a big solution to this kind of changing the bad proteins into good proteins or removing them. And not only, they also are called as a heat shock proteins. They are also called as heat shock proteins. HSP 60, 70, 90. I have been using chaperones for last 3 months in specific conditions, and they are the best in anti-aging. best in anti-aging. They are the best in organ failures. They are the best in neurodegenerative conditions. We have to understand the physiology, how they can work. In the disease pattern, chevron levels or heat shock protein levels have gone down. That's the reason the bad proteins are getting accumulated. So we need to increase the heat shock proteins. The moment you increase the heat shock proteins, they will improve the function of the quality management of the cell is improved. This is how the chevrons function. And what is more important, when I said I'm going to talk to you on I have spoken about the cells, I have spoken about the drugs which are produced by the cells, their molecular actions I have spoken you, which I am confident most of them have understood because I have tried to put them in simple, but I have not used any kind of very complicated basic science language. Looking at the cells and their profile as a drug, there's a huge promise for us. There's a huge promise for us to see future. These therapies can change our paradigm of medicine. And if you see, as I told you here, clinical trials are designed to answer scientific questions, not to provide an immediate cure. This is one which I insist every talk. They are designed not as immediate cure. Never expect that there will be a magic going to happen. But definitely, they'll give two aspects for us. One is a safety. Second, efficacy. And I always say, don't randomly use any molecule, expecting it will do miracle. Just try to go back, put yourself in a proper theme of protocol, go to the basic science of that molecule, their actions, and then use them. Probably your output of the result, when we talk of any therapy, output is very important. What is the outcome coming? Why most of the people fail in the outcome? Because they don't bother to look at this. And if you want to really have a good outcome, then this is must. The aim should be making a cell therapy reproducible, reliable, cost-effective, and accessible to all. When we talk, as I told you, when we talk as a molecule, it should be a reproducible with the same potency. Like a drug molecule, if you produce a drug molecule in US, in any of the factory, and India, any of the factory molecule, the potency of the molecule or pharma molecule remains the same. But that application cannot be applied to the stem cell. Reason being that there are challenges which I look as because the stem cells, with each manipulation, each handling, environment, temperature, their behavior change. If I give one molecule of stem cell and ask you to produce one lab here in mother cell, one lab in StemRx, one lab in US, the same at the end of 7th day, the cell structure will be, cell expressions will be different. Because these are living, breathing entities. They will change with the manipulation. They will change with the time, change with the petri dish handling, change with the environment. So what is more challenging for all of us is how do we standardize them? How do we standardize them? When we look as a drug molecule, these are the hurdles or challenges which you are looking for. And when we talk as a cell as a manufacturing from a bench to bedside, the harvesting, isolation, then expansion, differentiation, transformation, packaging, cryostorage, and distributions play a major role. This is an entire sequence, and everything has its own protocol design. And then it's a standardization. I repeatedly talk against standardization. Reason being that these are not dead molecules, they are living molecules. They will change. Now, if I had to send a cell molecule from here with a logistic to some other hospital, I cannot send it like a pharmacological molecule. You cannot store a cell molecule in a temperature of 40 for more than required time period. You cannot store. The cold chain of logistics plays a major role in this. So the application of into a therapy plays a major difference when we talk as a drug molecule. Talking about cell as a product, will be an empty promise if manufacturing is not supported by sufficient robust cell engineering innovations and cell product attributes. Now, we need to work on a hurdles first. The robotic technology which I'm going to talk to you, if we overcome these hurdles, reproducibility as I spoke, your reliability, stability, scalability. Scalability plays a major role. Go in any world, without scalability you cannot bring this as a drug, cell or a cell molecule cannot be brought as a drug. The quality plays a major role. Again, cell from a diabetic patient is different, normal patient is different, male is different, female is different, ethnicity is different, area is different. So again, this quality attributes a major role when you talk of a cell as a drug molecule. Then the cost, which is even today, the cost is a big hindrance, is a big hurdle in the treatment part. Individual is different story. When we talk as a masses treatment, we need to work on a cost very much. And the accessibility, as I told you, when we talk this molecule to become a molecule of mainstream of science, standard of care, we need to find the way of accessibility we can work on. These challenges which I spoke you, I have just enumerated. I may not read out much, but there is a one which I can explain you on the last but one area where stores, freeze, packaging and transporting. This is a major important when we are talking of a cell to be logistical center other places, which is very, very important. Then engineering advances. When you talk of a manufacturing, the human manipulation to manufacture the cell is the next impossible task. So we need to work towards the robotic technologies or engineering technology. So it's a big challenge, a big hub. We need a robotic technology engineers, electronic engineers to monitor the growth of the cell with various sensors, and then only we can maintain the consistency of the cell. And this consistency has to be checked every day. Monitor the cell proliferation. Expressions are to be every day. You can't say I am going to monitor at the 8th day or 10th day, and when you find on the 10th day the cell expected expressions are not happening, the entire batch has to be discarded. It's a huge cost effective requirement. So all those technologies has to be worked on in a very small, very manipulative way. And the last most important, I would say, supply chain management in case when you talk of a cell or drug to be manufactured. Supply chain, we all know in a labs when we are handling cells, we use all those cocktails of mediums. There's a limitation of various companies. If you see if you take a different company, different cocktail mediums, the result of proliferation differs. I hope Ravi will agree. If you take somebody, one company, second company and third, proliferation changes. So we need to standardize this supply chain from the companies which are supplying you, and then only you can standardize the process. You can imagine the challenges, hurdles when you want to take cell and cell product towards as a drug molecule compared to a pharmacological drug molecule, because there are so many challenges which I have spoken you today for you. The critical infrastructure is very important. The infrastructure which has to be supported by regulation. Without regulation, the infrastructure is useless. And I'm very happy to say you today, even India is trying to make the regulations very competitive like Japan or Korea, which is a very positive step. Probably we will see future for stem cells very beautiful for India. It's going to come. It's all things are pipeline, and I'm hoping that another 1 year or 2 years, most of things will be clear for all of us to practice regenerative medicine as a science. Now, there is a regulation for every therapy to practice. If you see the way FDA is there for pharmacology molecule, simply the cell transplant when we talk of is like an organ transplant. It's like an organ transplant. Sometime I have given a talk which I want to say, can we use cell transplant replacing the organ transplants? It's equivalent, like when you talk of an organ transplant, is a total billion cells to be transplanted with its own system, whereas a cell is a transplant to repair that entire billion cell environment. Again, a similar like. There are rules different for different regulations. Like in organ transplant in US, there's a HRSA is a regulatory body which has made the rules regulations. Similarly, the biological products and biological application cannot be put in the framework of pharmacological molecules because they are living being entities. We can't put into clinical trials as they are put for the pharmacological molecules. So we have to bypass phase 1, phase 2. How we do take them into phase 3 or autologous therapies which can put into phase 3 trials. Goal for the future, delivering the cell therapies to patient and population as I spoke you. Manufacturing of high quality potent cells as a standard, consistency. Reproducibility plays a major role. If you cannot reproduce, the cost will remain high. So if you are talking, I want to treat an OPD for regenerative medicine therapies, and I have got 20 patients outside, and if you cannot treat them with the reduction of the cost, then the therapies cannot be therapies of masses. With the regulatory policy and reimbursement framework, today we have a lot of limitations for applying stem cells into clinical practice, again a reimbursement policy. Because when it ends up to spend from your own pocket, there's a limitation for everyone. So we need to work up on a regulatory insurance frameworks, which plays a major role for therapies to come as a treatment part. Otherwise, they will remain as an independent therapy. If you talk as a drug and if you want to take it to masses, then we need to think in a different line. Can we put all this structure into a reimbursement framework? Yeah, it is possible. For good things that there are some of the Indian insurance companies are already working positively on stem cell reimbursements, which is a very good news for all of you. And they are actively coming, and down the line, a year or two, you will find many of them will come because they are getting regulated now. So I am looking at a future beautiful for all these therapies. Need for public-private partnership. This is a very important aspect which normally I talk. These diseases which I'm going to talk to you today are chronic, debilitating, and cost-effective, requiring a long hospitalization and huge cost involved. The huge cost involved is always a burden to the treasury of the government and the states. Now, if you think these therapies can change the future for these all chronic diseases which we spoke about the challenges, the entire treasuries of the government are going to see $1 billion. So this is what we need to present from our association to look in how we can effectively change the state policies to apply for these therapies. Now, what is more important is the long-term benefits. Yes, they have a long-term benefits. The economy and the job creation in biotechnology. Now, you, me are sitting are not the people like PhDs, MSCs or doctors are not going to work in the lab to produce the cells. We require technicians. So we need an occasional school to produce a brains to handle the cells, which we don't have. Again, a big challenge, which is a hurdle, which we need to work on it, like enabling innovative globally. Globally, we need to create infrastructures which can communicate to share the technologies and bringing stakeholders together like institutions, academia, industry, clinician, and stakeholders. States, they need to come. If we are going to talk, the science of biology is going to become a drug and cell is going to become a drug. After all doing this, we cannot deliver in a healthcare system. The stem cells and drugs cannot be put into the healthcare management system. Today's healthcare management system is designed to have surgical and pharmacological effects, not to regenerative medicine. So we need to work on this health delivery system also. So this is like a small village I call. When we talk drug and cell, we involve here clinicians, biologists, biomedical, chemical engineers, manufacturing and the hub industry, regulatory boards, standard organizations, then patient advocates are required in these to get into an ethnicity of the treatments, insurance reimbursement as I spoke you, then the IT industry will come in the picture, electrical engineers and information technology to create a huge data what we got. Data is again playing a play role. So it's going to be a small village when we talk drugs and stem cells as an application for future for all of us. And I believe it's not a big journey. All major industries and major government regulatory bodies and clinician bodies are working together. This is what the total information on stem cells and drugs, which I would like to share with you and I have shared with you. I believe you have an opportunity to share with me your questions today. And if anything are difficult for you, which I communicate not understood, you can ask me now or afterwards, or you can take my number or you can email me. I'll get in touch with you to give all these kind of detailed solutions for you. When you are thinking you want to become a clinician with regenerative medicine, we need to go through these all phases. Thank you for patient hearing. As well, I hope I could contribute today something which is beyond the horizon of clinical practice today. Thank you once more.
Thank you, sir. I now request Nitya Kalyani ma'am to give away the bouquet to sir. Dr. Nitya Kalyani, doctorate from Madras Diabetic Research Foundation, PhD thesis was nominated for the top best thesis by the University of Madras. Senior scientist, Apollo Institute of Transplant at Apollo, Chennai, has established chondrocytes technologies, Udocell Slovenia EU, endorsed her skills of islet isolation from Oxford Center for Diabetes, Endocrinology and Metabolism from United Kingdom, endorsed her stem cell technologies from LifeCell International, currently into development of human pancreatic islet cell transplant, has worked on all sort of human sample for clinical isolation such as vitreous sample, aqueous sample, cadaver eye, skin biopsy sample, amniotic membranes. Tamil Nadu Innovation Voucher Award by the Entrepreneurship Development Institute of India, selected as the top 5 contestants by the Andhra Pradesh MedTech Zone, and Women Entrepreneur, Director of Cells to Cure Therapies. Over to Dr. Nitya Kalyani ma'am.
So everyone here, you have been talking only about the solutions. So I'm just going to talk only about the problems which I'm currently facing. So human islet cell transplantation to cure diabetes. I'm pretty sure it's quite very ambitious, but I think that we have kept our baby steps forward to make this a clinical reality. Myself, along with Professor Anil Vaidya, we both are working towards this. So India, I think diabetes needs no great introduction because Dr. Anil Bansali sir, Dr. Pradeep, everyone have given a great introduction, and they have been talking only on the type 2 diabetes, and they have been telling that islet transplantation is also not possible also to some extent after a period of 5 years. So I am just here to talk on why do we need islet transplant center in India. Being in a diabetic capital, we don't have islet transplant centers. As of now, anti-diabetic medication and insulin have been the only prime of treatment. Surgical, whole solid organ transplantation has been in on practice, but there are no great strategies to improve the survival rate of that. So why is it that in a diabetic capital, we have been discarding away the pancreas? The basic 2 reasons are the regulatory hurdles. As per the Transplantation of Human Organ Act 1994, organs cannot be used for the purpose of research. It can be used only for therapeutic applications. So when we were so excited to start this particular work, the first stumbling block was like, you cannot do it because it doesn't come. And in case if you just cross over it, you will be behind the bars. So the next set of things which we had a problem is that the lack of infrastructure facilities, a proper CGMP facilities. I'm pretty sure Dr. Pradeep has one, beautiful one. Dr. Naina ma'am also has one. Those are the clinical grade for doing the islet transplantation is not actually fully satisfied in these labs also. So not only this, our main concern is on type 1 diabetes, that is the brittle diabetes, where it leads to hypoglycemic unawareness. And the next thing is on the type 3C, chronic pancreatitis. So chronic pancreatitis can be cured by autotransplantation, and type 1 diabetes can be cured by allotransplantation. So when we were thinking about it, is there a common methodology to treat or cure both the conditions? The answer is yes. Islet cell transplantation was the only answer. So once we started, what the problems we had, this is a very simple slide stating the diabetics why India needs an islet transplant center, because considering 84 million of type 1 diabetes, and the whole of Southeast Asia is the home to the diabetes capital of the world, and you could see India followed by Bangladesh, Sri Lanka, and Nepal and Mauritius are the states, the countries which are in pipeline. So when we proposed this to the minister, health minister, Dr. Vijay Bhaskar and Dr. Radhakrishnan, we suggested that In India, I mean, especially in Tamil Nadu, because a lot of healthcare missions are happening in Tamil Nadu. So we said from 2012 we have been just discarding away the pancreas into the bin. So he gave us a permission. He said we had to analyze the thing because it is an act and all. So we had a great round of discussion. At last, like, we are now in a position where we are allowed to use the pancreas for the purpose of research. And this is also specifically only for 2 years he has given us a permission. And this is the thing which with respect to Kerala, how many pancreas are basically discarded. Out of 290 organ donation, only 10 pancreas are used for the solid organ transplantation. In Andhra Pradesh and Telangana, only 8 out of 644. So I would like to place a strong statement here. Professor Dr. Anil Bansali was stating that there are not enough of organ donation which is happening in India. To my knowledge, I feel that's not the right thing, because we have enough of organ donation, but the ratio of 3 to 1 for the patient, that is also actually not true. Now in Western countries, it has reduced as 1 to 1. From 1 pancreas, you can go in for 1 islet transplantation. So these are the functional islet cell transplant centers across the globe, the pink hoisted flags. So we can see that in India there is, or in the whole of Asia, I should say, there is not even a single islet transplant center. What is the phase 1 going to be? To establish India's first islet cell isolation unit, to drive the innovation through bioengineering, and of course, to address the need of the hour in India. So what are the basic resources which is needed for this? The islet isolation team, the donor organ team, the islet isolation lab. These all is governed by the regulatory hurdles. And after that, it's the clinical trials where we need to test it in the patients, the clinical team and the patients. And we felt that overall the Indian clinical governance plays a very important role in all these things. So this is how the basic islet laboratory plan has to be, the GMP plant. So it starts with the change A, the preparation room, the culture room, the isolation room. Even in the isolation room in the Western countries, they have a separate set of procedures, starting everything. Once you have an organ or pancreas, it has to go through a perfusion in one chamber, the digestion is a specific chamber, purification. If you go to another Edmonton or other places, they have a separate room, isolation room itself. Here at least it's a big lab and divided by chambers, but there it's a whole room itself. So, and here next I will be explaining on how the process goes. So once you have the pancreas, it is digested in the Ricordi chamber, and this is how the crude population along with exocrine, endocrine will look like. This is my own work at Oxford. So once you have the crude population of the pancreas, the basic thing is it has to be digested in a Kobe mission. It's COBE2991 processor is a mission purification mission which basically purifies the islet cells. This plays a very crucial role, and this is why most of the islet transplantation also sometimes fail, because the purification step is not all that efficient, because each and everyone follows a different kind of purification step. So this is how, after the purification, this is how the isolated human pancreatic islet cells will be. So in a nutshell of the flow chart of the whole, once you have the organs, it is digested using specific enzymes, the pancreas get distended, then it is totally purified by the Kobe mission, and it will be infused back into the liver. So this is on the whole process. I think most of you as clinicians, I think you will be aware of this also. So the basic product release criteria for the islet transplantation is the purity, viability, and what are the basics, the dyes we use for analyzing the dead cells and the live cells. This is what is over here. So what we have done till now here in India, we have been happily talking that type 1 is a neglected complication, type 3C is a neglected complication, and it leads to a 6-fold increase in the death rate. We have been happily publishing alone. What is the action taken? So what we did is, once we understood the whole process, we got a special permission from our minister and our health secretary, and they gave a special GO called as 1493, where the organs, as I said, can be used for the purpose of research. Once that was cleared, we got a lab and we thought we can start the process. The next set of problem arose, and we couldn't get the Kobe mission because it is not, it's not a registered product under Indian Medical Equipment Act. So I was not allowed to do that also. So we need to go convince the SITSCO for all these things, and we have got the clearance also. Luckily, Professor Bansali sir and Dr. Ashish Sharma are also in place in the future for the clinical trials and the clinical validation. We have placed our foot with ICMR also. They are very much open towards it. So once they give a clearance, it will be like a pan-India of clearance. It's just not restricted only towards the Tamil Nadu. It will be towards the entire country, so that we'll be getting the organs. Then the question of how much of organs will I be getting it for the purpose of islet isolation will not be a big thing. So at least in a day, if I'm able to get one organ donation from any part of the country, because now the logistics or the green corridor system has opened up so well, and I think it should be possible. So this is the government order which we have achieved from the state of Tamil Nadu. This is the special approval from the Department of Medical Services to carry out this particular project. And this is the Kobe mission which I was trying to explain. It is not registered under the Indian Act and Indian Medical Equipment Act, and we have got this registered with the SITSCO. And once we are done with the proof of concept, it is like we have just started up with the process now. I could say we are just baby. And once it is done, what are the next level of operations will be? The CGMP has to be in place, along with the CTP, the cadaver transplant program list from different parts of the country has to be there. The training, the regulatory clearances, this all will lead to a clinical islet transplant program. So this in the future can serve as a gold standard therapy, and not only that, the sustenance of the islet cells in the system, because there are studies which says that it is viable only for a period of 10 years or 5 years only. So we are like in the process of having 2-3 patents also, so that's the reason I have not enclosed it. So we'll be micro-encapsulating it with our own kind of material, so that islet cells can be used and the patients doesn't even have to take the immunosuppressants. That is one thing. And we are planning to create a living scaffold-based system, so that first we will be testing the function of islet cells in the in vitro system, and once it is perfect, and then we will be shooting it inside the system. So this is also one more thing which is there in the pipeline, which we are trying to achieve it simultaneously. So I hope that opportunities lie ahead with the development of islet-friendly immunosuppressants and the possibility of tolerance induction and improvements in the islet yield implantation. So this is a project of a high magnitude, because we'll be the first in Asia to take it up and do it. So it needs a strategic partnership. So we are blessed to have a good partnership with Oxford University, where I really got trained. Dr. Balamurgan also is one of my mentor. Dr. Thierry Burney from University of Geneva. And not only the international collaboration, the national collaboration plays a very important role. Dr. Shantaram was the main key person who was involved in getting us the GO from the government of Tamil Nadu. Dr. Ashish Sharma and Professor Bansali sir. In the future, with respect to the clinical validations, we have kept a platform on that. And Dr. Mohan is also equally interested on the type 1 diabetes. Once we are into the market, like he will be selecting the diabetic patients for us in the future. So our team, Professor Dr. Anil Vaidya. So without him, I think I'm nothing here. So he is the one who has been constantly boosting me up in doing few things. Myself, Dr. Sendil Kumaran is the pancreas retrieval surgeon for us, and Dr. Nivash and Dinesh on the anesthesia. So our journey begins, hopefully. By 2021, I think I'll be having the proof of concept ready. Thank you.
Thank you, ma'am. It was really enlightening. I now request Natesh Prabhu sir to give away the bouquet.
Good afternoon. Nice introduction is given by Rangapriya. We are together from 1980. We did a BDS and MDS and research work, clinical application for more than 10 years. We are doing the cases together. So small definitions I am giving for the regenerative medicine and surgery. The regenerative medicine involves treating the patient by topical application or injecting cell-based material, growth factors, secretomes to reverse the pathology. This is the main concept. We should understand any disease of the pathology, try to reverse the pathology. This is our main motto to treat all the patients, to repair the tissue and organ. Examples for, we are using bone marrow, mononuclear cell injection for the submucous fibrosis, neuralgia cases, TM joint pain, arthritis, diabetic foot ulcers, tendon ligament injuries, hair regeneration, and cardiology, orthopedic and ophthalmic. Every field you can venue for application for these materials. Next is the regenerative surgery. There is a difference between the regenerative medicine and surgery. Surgery deals mainly with removal of pathological tissue. In regenerative medicine, we are not going to remove any pathological tissue, just we are going to apply over the diseased area to regenerate or reverse the pathology. Here we are going to remove the pathological tissue and produce some defects in that area. It may be from soft tissue or hard tissue, or both the soft tissue and hard tissue. Without sacrificing the normal tissue, we are going to regenerate that defect. The last portion of the defect is replaced and augmented with the cell-based material, growth factors, again the secretomes, with or without graft material. Here it's important is scaffold. So for the medical application, we do not need any scaffold material. Whenever there is a defect, we need a scaffold material to hold the stem cells or secretomes, growth factors in that area to act and regenerate the last portion of the tissue. So we followed this procedure for the treating the extraction socket to regenerate, periodontal bone regeneration, and cystic lesions, ameloblastoma, and pathological lesions in the jaws of the bones. And important thing is here we are going to restore the normal anatomical function. Also it's important, when you do the pathological, normally what happens, no, they resect and throw it off and reconstruct with the somewhere taken bone from the iliac region or from the hip region or from the leg region to reconstruct it, even though we are not going to compensate the functional and anatomical and aesthetic things. So we can, by regenerating thing, we can preserve the anatomy, function and aesthetic. It's a very important thing in the regeneration. So regeneration requires main three things. One is the cell, another one is the scaffold and signals. So regenerative materials, what are the things we use in our 10 years of duration? First we start from the umbilical cord stem cells, but we are not get good results for regeneration. Then we move to the autologous dental pump stem cells and allogenic dental pump stem cells. Then go for taking the buccal pad of the pad from the patient itself, and autologously we prepared somal vascular fractions. Then move to the abdominal fat for the SVF, then bone marrow concentrate. Finally, this is approved by the government. We are now using this bone marrow concentrates with or without corticocancellous bones, and we are using that autologous platelet concentrates and platelet fibrins, and finally we will end up in the freeze-dried platelet-rich plasma. So here is important for the biotechnology people will play a main role in that. The doctor cannot prepare the everything, so we need assistant for doing all this work. So biotechnology field will have a more job opportunity when they learn to how to prepare the concentrate of the bone marrow stem cells and how to separate the stem cells from the lab to the clinical side. This will be helpful for them, for both the doctors and the biological students. Then scaffold. What are the scaffold so far we used in our practice? One is the Cybograph T. This is a trade name. It's containing the beta tricalcium phosphate. After that, we move to the Cybograph H, that is containing the hydroxyapatite sponge. These are available in the various sizes, smaller size to the larger size. According to the defect, we are using this. Then collagen powder, which containing the hydrolyzed type 1 collagen extracted from the fish shell. It is a powder form. We dissolve it and we can use it. Then Abgel, it's a gelatin sponge. Then we can use autologous platelet-rich fibrin. Then now we are using that Oseo mold. It's containing the demineralized bone matrix, genograph type 1 collagen. It's available as a powder and granule form. It is containing the calcium sulfate also, hemihydrate, which will help in bone regeneration. Then finally, we are using the autologous corticocancellous bone to fill the bone defects. So these are the material we are used for the as a scaffold. But still today, there is no ideal material is available to use as a scaffold. There is a possibility and venue for preparation for going for making scaffold is available. Then come to the signals. So signals are produced from the disease itself, or when you do the surgical procedure, that surgical procedure produces trauma. From that inflammation, signals are produced. So when you place the stem cells, it will help to regenerate. Signals will stimulate the stem cells and surrounding cells to produce bones and soft tissue to regenerate the bones in maxillofacial region, not alone that, from wherever in the body. So action of these signals produce trans differentiation, paracrine effects and cell fusion. That stem cell itself change to the native tissue when it is maybe bone or soft tissue, whatever the things, or it stimulate the already present stem cells in that region, stimulate and change into the bone or soft tissue like that. Paracrine effect means that produce growth factors or cytokines that will produce the stimulating the nearby cells to change into the bone or soft tissue, whatever we need on that area. So basic approach to the treatment, one is the placing or injecting appropriate regenerative material over the affected area. This is mainly for medical use, for injecting, for example, for submucous fibrosis and arthritis, knee, ligament injuries, TM joint problem, like that we are directly going to inject or placing that material to that particular diseased region and to reverse the pathology or regenerate that area. Then next is the approach is removal of pathological tissue. When there is a cyst or tumor, we cannot just inject these stem cells in that area, it's not going to act. So we have to remove pathology, tissue, and defect is filled with the regenerative materials with scaffold. So that will produce the native tissue on that area. So next come to the clinical applications. So far, what are the cases we done for past 10 years? So ameloblastoma and OKC for 10 cases, and osteoradionecrosis for 5 cases, and submucous fibrosis for 15 cases, hair regeneration around 20 cases, cystic lesion more than 25 cases, and impaction, removal of the last molar tooth, and that bone is regenerated, more than 200 cases, and maxillary sinus lift, when we are going to place implant for replacing the tooth, for that we are using that sinus lift technique to regenerate that bone, that area, for 2 cases, and implant for more than 25 cases. This is case of ameloblastoma. We treated around 14 years of the boy. Now the boy is 21 years. Still there is no recurrence. This is the ameloblastoma. There is a possibility of recurrence is there. So normal treatment is going to resect the jaw from the molar to molar region and going to reconstruct with the bone from leg, fibula. So here we are planning for reconstruction. We have removed upper one premolar tooth. From that we extract the dental pulp stem cells, and in our lab we culture the cells, and if are not getting adequate cells, then you go for buccal pad of the pad from the patient itself. So we used for this patient both dental pulp stems autologous and autologous somal vascular fraction prepared during the surgery, and we placed inside that area and regenerate the last part of the mandible, and we preserve the tooth also. Only few teeth are extracted with bone damage is more in that area. Then rest of the tooth we done a root canal and save the tooth also. So now we are planning for this patient for implant placement. So this is done under free of cost. We spend more than 60,000-70,000 rupees for this patient from our lab. And surgical fees also be not considered for that patient. We are not charged for anything for that patient. It's done in our college. Next is the keratocyst. This is we used bone marrow concentrate and corticocancellous bone. This case is done at Chennai. So this case also we are not extracted for this type of a bigger lesion. Usually we will remove all the teeth, or we will remove the entire part of the bone. This is also be a possibility of the lesion is recurring, keratocyst. So we used bone marrow concentrate and corticocancellous bone to regenerate mandible, and also we can did a root canal treatment for that involving tooth, whichever the tooth is not vital. We are done a root canal treatment for that patient. So this is followed for more than 2 years. Then this is the case of osteoradionecrosis done at our institution, Kesar Dental College. This is more than 1 year old osteoradionecrosis with extraoral sinus. We use dental pulp stem cells, allogenic dental pulp stem cells to regenerate the affected part of the bone. So excise the sinus tract also. We see that healing of the wound in the skin also we cannot able to see the scar. Intraorally also there is a change in that mucous membrane. It is normal in color. Previously it is black in color. The salivary secretion is not there for the patient. After this treatment the color also changed, come to the normal oral mucosa, and also patient having a normal secretion of the saliva also. Then hair formation also be start taking place. This is the thing we are published in the article. And next is submucous fibrosis. This is the case done by Dr. Shankar Narayanan. More than 15 cases over Trichy and Chennai, both the areas. This is I already explained that how to take the bone marrow from iliac bone and how to concentrate, and we are going to inject the things into the buccal mucosa. Here also the biotechnologies help also very important to prepare the concentrate. So the hair regeneration also done by Dr. Shankar Narayan over here. Laser assisted PRP topical applications and PRP prepared from the patient itself. Autologous preparation of PRP is injected into the patient scalp to regenerate the hair. Next is the smaller cyst to bigger cyst are treated by the in our college and my private practice also. Usually this type of cases we extract the tooth which is involved in the cystic lesion. So here we plan to, even there is a very minimal bone is there, we try to preserve the tooth also and did a root canal for this patient and remove entire cyst. Here we are used cybograft and the PRP applications. Here it's not possible to take stem cells from the patient and apply it. Here the important thing is PRP preparation for powder form is very important because easy to apply to the patient. So you are able to see that bone regeneration happens. Then after that we are going to place the prosthesis over that region to lost tooth in that region also. This is the smaller cyst. The another case, the largest cyst from maxilla, from one side of the right side of the premolar to left side of the molar. This is a bigger cyst and involving lot of the bones, distraction and everything. The patient went somewhere else, they advise extraction of all the tooth and replacement of prosthesis. Advice for the bridge replacement. But we are advised that patient not necessary. We can proceed with root canal treatment and remove entire cystic lesion. And it is done under our college in the local anesthesia only. And we are used a buccal pad of the pad from the patient, prepare the buccal pad, SVF, and place inside that with scaffolds, and it is regenerated. The patient reported after 1 year without any recurrence or any tooth loosening or anything. Everything will be fine. Clinically, patient have a nice oral mucosa and bridge also we have to place for this patient. Then next after removing the last tooth, usually commonly we come across that bone will be reduced on that site. So it will expose the neighboring tooth root surface, that is the second molar, and expose the root will cause the sensitivity for the patient. And also there is loss of bone distal to that is behind the second molar. To avoid that, we have planned to regenerate every cases after doing the removal of the tooth. We just place the PRP dry powder inside that and close the wound. That will one thing will happen. First is the bone regeneration will be nice, and post-operative infection is less, inflammation is less. So we reduce giving antibiotic, anti-inflammatory for that type of the patient. So we did around more than 200 cases of impaction cases. We placed this material. Then next come to the sinus lift. I told you there is maxilla, very less bone. The bone is when you try to place, we are going to enter into the maxillary sinus. There will be a possibility of communication between the oral cavity and the maxillary sinus. To avoid that, we have to regenerate bone in that maxilla and place the implant, or we are placing the implant along with we are placed the graft material over that region and regenerate. Wait for 6 months. After that, we place the tooth over that region. This is the case done 4 years back. So, and our publications are internationally we published 3 publications and national 6, and book chapter is 1 we did. It's our team, both here and in college. Okay, thank you for the lecture.
Thank you, sir. I now request Dr. Ravi, sir, to give away the bouquet to Manikumar. Sir, just 2 minutes. He has some questions to ask.
For very smaller defect, it's not necessary to place the scaffold. Just you can place the powder inside. And the only thing is you have to do the primary closure. That's very important.
Okay. After the primary closure, if there is any seepage of liquid or
nothing will happen. Once the blood clots start forming, it will be.
So antibiotic necessary or not necessary,
not
or
necessary.
anti-inflammatory?
Not anti-inflammatory is not necessary.
So nothing, antibiotic or
Antibiotic
NSAID?
also not necessary. We tried more than 10-15 cases.
Not used at all.
In private practice, we want to give very mild dose of amoxicillin and paracetamol you can give. Not necessary to give Moxclave, like that drugs, higher antibiotics.
But prophylactically, you are giving, no, at least for 1 or 2 days.
Prophylactically you can give. After surgery, it is not necessary to give drugs.
It's for the valedictory function. Principal Professor Sundar Raman sir from National College. I welcome Dr. Manimaran sir. Dr. Avinash sir. And Dr. Zamir Mohammed, HOD of Biotechnology Department, National College. The first place from Bharatidasan University, Trichy, Karthik Raja A. And Kaushika K. from Bharatidasan University. I request Principal Sir to give away the prizes. Yeah, I'll just read everything. The second place is for Baby S from Bishop Haber College, Trichy, and Pavitra Kray from AJK College of Arts and Science. And the third place goes to Janaki S from Periyar EVR College, Trichy, and Prakash R from Bharatidasan University, Trichy. And for the poster presentation, the first place goes to Sri Durga. The second place goes to Sai Shweta from SRM Dental College. She is Sri Durga, first place in poster presentation. Second place goes to Sai Shweta from SRM Dental College. Third place goes to Priyadarshini N from Mahatma Gandhi Memorial Government Hospital, Trichy. Thank you. And now I request Dr. Avinash Gandhi to give away a few words.
So the entire day started with the good informative talks, and now we are finalizing with the informative minds. With this as a lead and step towards of new thinking, open up more opportunities not only in regenerative medicine and cell culture, but also as an entrepreneur, so that you can have a scope as an biotechnologist to have your own setup or startup for your bright future. So I just wish everyone who has participated in this event to have a innovative future for your life. Thank you.
I just would like to stress upon 2 points which my dad used to tell me, and he was telling his students as well. One thing, whatever we find, whatever research we do, shouldn't stop with the laboratory. It has to be for a clinical purpose. So our thinking or research projects should always be beneficial for the patients, and it should come as a product, or it should come into the market. It shouldn't just stop with the in vitro studies or the cell cultures or within the walls of the laboratories. That's number one. And number two, it's what the whole conference was about, from era of resection to regeneration. So that should be our motive and vision. And number three, it's the reversing of pathology. The nature has given us the immense science to even reverse the pathology or reverse the disease, where we can bring it to normal, and we as future scientists and clinicians has to work for it. So on this note, thank you all for coming for this conference, and Jai Hind.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल उत्कलवङ्गा विन्ध्य हिमाचल यमुना गङ्गा उच्चल जलधितरङ्गा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे